All right,
Hi,
we're live.
everyone.
Awesome.
All right, sounds good. Hi, everyone. We're here tonight for our first session of the Craniosynostosis webinar series. We have we have an awesome group of faculty lined up for these sessions. The next will be on February 7th. Just some quick announcements before we get started. We encourage you all to join us live every Thursday for the neurosurgery journey, which is a continuation of our podcast series. Then live tomorrow night, we have our Injuries of Freedom session. And then we also have an ongoing webinar an ongoing fundraiser until February 14th. For those of you who are able to support us, we really appreciate it. So to get started, we have Dr. Bonfield here tonight with us. And we're very excited to have him do our first session on the overview of craniosynostosis. He serves as Associate Professor of Neurological Surgery at Vanderbilt University Medical Center, alongside his roles as Director of the Adult and Pediatric Neurosurgery Scoliosis and Spine Deformity Program, Director of the Pediatric Neurospine Program, and Director of the Pediatric Craniofacial Program. In addition to his clinical interests in pediatric neurosurgery with an emphasis on craniofacial surgery and spinal deformity correction, Dr. Bonfield's adult spine practice includes complex spine reconstruction and deformity correction. So his neurosurgical expertise extends to the global community as well through his active involvement in global neurosurgical outreach. He's provided neurosurgical care in underserved communities such as Africa and South America, and continues to support global neurosurgical efforts in his role as director of the International Neurosurgery Program. Dr. Bonfield's extensive medical training began at the University of Pittsburgh School of Medicine, where he received his medical degree and subsequent neurosurgical residency training. He then went on to complete a fellowship in complex spine surgery and subsequently a subspecialty in pediatric craniofacial surgery, followed by completion of a pediatric neurosurgery fellowship with training at BC Children's Hospital in Vancouver. So thank you so much, Dr. Bonfield, and I'll hand it over to you.
Great. Let me see if I can share the screen. Okay, how are we looking? Good? All right. So thanks very much for bringing me in tonight to start your next series on skull deformities, craniosynostosis, and how we treat that. I hope everybody is staying warm out there. I know down here in Nashville, it's unusually cold and there's call for ice, which in the South tends to shut things down. So I hope everywhere else around the country, people are staying warm and staying safe. So craniosynostosis and corrective surgery. Today is going to be a big overview, sort of the 30,000-foot view of what craniosynostosis is, introduction into how you diagnose it, what it looks like, how to treat it, maybe some of the genetics behind it, but sort of a big overview of it. Disclosures, I don't have any personal disclosures. There are photos in here. This is a talk about cranial deformities, and so you'll see people's skulls and faces, and all the photos were used with the parents' permission for educational purposes such as this. So the objective tonight is to recognize the common head shape patterns of craniosynostosis and the deformational plagiocephaly, which, as you'll see, is not a pathologic issue and doesn't require surgery, but many kids have that. And we have to know the difference between what is deformational plagiocephaly and what is actually synostosis and needs treatment. Be able to differentiate craniosynostosis from deformational plagiocephaly, as I said, understand the treatments for craniosynostosis and plagiocephaly, and explore different surgical options, open reconstructions, and then minimally invasive techniques. And I know there's going to be more detailed talks on those later on in your series, but we'll introduce those tonight. So we'll spend most of the time on the overview section over here. What is craniosynostosis? When did people start thinking about it? How do you classify it? Where does it come from? What do the genetics look like? Why does it shape the skull like it does? How do kids present? How do you diagnose it? And what's the treatment? And in doing that, we'll look at the different categories of synostosis, mainly the simple single suture synostosis, which is the most common. About 80 to 90% of all of the synostosis is this. We'll mention the complex synostoses and the secondary ones, but they're less common, so we won't spend as much time in that. We will talk about plagiocephaly and possibly the role for helmets, surgical treatment for synostosis, and then future directions about what research is going on. So what are we even talking about? Craniosynostosis is essentially the premature closure of one or more of the cranial sutures. And more often than not, it's single suture. As I said, that's about 85% of them only have one suture fused. And when we say sutures, what are we talking about? We're talking about growth plates in the skull. And so in the infants and the babies, for at least initially when they come out of the womb, there's different growth plates on the head that allow the bones of the skull to come out of the mother, and to also make it so that as the brain grows, the brain pushes things out from the inside, and the skull rounds out and is able to be grown essentially by the brain pushing out. The sutures that we're talking about, the main ones, are the sagittal suture on the top of the head, the metopic suture on the front of the head, the coronal sutures coming down the side in the front, and the lambdoidal sutures back here coming down the side on the back. So when we talk about the main sutures, those are them: the sagittal, metopic, coronal, and lambdoidal sutures. And if you look over here, these kids' head shapes all look different. They have the same underlying pathology of one of the sutures that are closed. In this case, it's actually bicoronal, so it's both of the coronal sutures, but it's one suture that changes all these head shapes. And you can see that they all look very different. This one's long and narrow. This one has a triangular forehead. This is tall and short. This one's asymmetric from the back. This one's asymmetric from the front, and it all depends on what suture is fused. The incidence of craniosynostosis is thought to be about 1 in 2,500 live births, so actually pretty common. And it's most commonly what we consider idiopathic, so not associated with any genetic syndrome, which we'll talk about, or any sort of metabolic disease or secondary to another process such as hydrocephalus shunting. Is if you pull down the brain from the inside and the brain doesn't have a chance to push against the sutures, sometimes they confuse as well, but that's secondary. But the main thing we're going to be talking about is single suture synostosis and idiopathic synostosis, which go together. So when was this first recognized? Everything seemingly comes back to the Greeks at some point, at least from the written record. Hippocrates describes the skull and suture anatomy. Herodotus talks about a skull without sutures. Galen talks about oxycephaly, meaning that the head was tall. This is about 400 BC. Skip a bunch of years until about the 1800s when we start talking about what causes this, what is synostosis. Otto recognizes that it's the sutures that are closing. Virchow's law we're going to talk about, and that it tells us which suture is fused, what pattern of the skull you're going to see. Lanolong performs a strip craniectomy where they take the suture out, which is, we've kind of gone full circle by going maximally invasive, and now some ways we can do a strip craniectomy, but with the help of springs or helmets. Curzon and Apert describes their syndromes, which we'll talk about. Moss talks about a functional matrix, which is maybe it's not just the suture, but it's the overlying skin and the muscle and the brain and the dura and everything combining that tells it with the brain or the skull how to grow. In France, then we have more transcranial approaches to the midface and orbits. Tessier starts this, and he's sort of the grandfather of what we consider modern craniosynostosis surgery. It's amazing they did all this prior to CT technology. John Jane introduces another cranial vault reconstruction procedure, which we still use today. Jimenez performs endoscopically minimally invasive procedures in the 1990s. And so it starts a long time ago. It gets a little more traction, and we've kind of gone in different cycles about what the best way to treat these kids are. We'll talk about the single non-syndromic sutures, the complex multi-suture and syndromic, and then secondary, many less on this compared to the single sutures. So epidemiology, we talked about overall 1 in 2,000, 1 in 2,500, somewhere in that range. The sagittal suture is the most common, with about 1 in 5,000. Curzons and Aperts, when we start getting into genetic syndromes, you can see the difference. It's about 5 to 12 times less common. So 1 in 25,000, 1 in 60,000. Gender is equal in some of them. In the sagittal and metopic, it's a little more males to females. So we see a little younger kids that are males present. Race, nothing has been shown with this as far as which races get synostosis a little more than others. There may be some talk about geography, which goes to race as well. But at this point, that hasn't been borne out. Etiology with genetics. We know that there's some genetic basis here. We talk about growth factor receptors. And when we talk about all of the syndromes, they do have genes that are recognized. We see them over here. I list these not to memorize or go through them tonight, but as we see, even the non-syndromic sutures, that's what NSC stands for, still has genes that are involved, and there's loci and mutation-specific ones that are recognized. But there may be up to 4 or 5 different ones for each suture that's fused. So there's not a 1-to-1 ratio when it comes to these non-syndromic types. For the syndromic type, it's a little more clear. We talk about intrauterine head constraints. So maybe the baby is stuck in one spot inside the mother, which corresponds with twins. There's not enough room. A head gets put in one position. The sutures are close together for a long amount of time and they begin to fuse. Maybe born out, maybe not. Maternal smoking, maybe that causes a little more rate of synostosis. And in the non-syndromic sutures that are fused, it's only about 8% that are passed on in the families. So when we talk to parents who have a kid with craniosynostosis, it's unlikely that other kids in the family have it. It's unlikely that the parents have it. And it's also unlikely that the kid who has synostosis will pass that on to their kid. So it is genetic in the sense that genes are involved, but not genetic in the sense that it's passed on in an autosomal dominant fashion or other ways that the syndromic ones are. Syndromic, we'll look at these a little more in detail. They all have clinical features. They come with other neurological symptoms as well. Most of these are autosomal dominant. So if you see one, oftentimes or more often than not, one of the parents has it, it's passing through the family. Again, it's these fibroblast growth receptors that we're going to talk about. But you can see it's a little more focused on which genes cause these compared to the other ones. Fetal embryology, just a quick throwback. It's the tissue in the skull starts forming around 23 to 26 days. The parietal bone are about 2 months. The sphenoid wing and other bones, 9 to 10 weeks. The occipital region, the back of the head, maybe the 3rd trimester. And bones in the heads form 2 different ways. Some of the mesenchymal progenitor cells turn to basically osteocells, which are bone cells. They grow together in kind of like flat bones where they grow from the middle out, and it's all bones the whole time. That's what the top of the skull is. And then there's the second thing is mainly cartilage, so chondroblast. And the skull base forms this way because you have to get the blood vessels out of the head. You have to get all the cranial nerves out of the head. And these are the ones that have to form around it. So the nerves form, and then the cartilage forms around that to allow for those fine tissues to get through, the fine nerves to get through. And then the cartilage turns to bone. And so we look at these areas in between different types of cells. The frontal bones, these neural crest cells, which you learn about in med school. The parietal bones are more of the mesoderm cells. It should stay mesoderm for a while before it turns to bone. Sometimes the frontal bone neural crest cells get in early. That causes those cells to fuse earlier and turn to bone before they're supposed to. In the syndromes, when we look down at the actual cell levels, we talk about fibroblast growth receptors. That's these FGFR. And we talk about twist. And what happens is downstream, we have RUNX, which turns osteoblast into bone. And so both of these things either turn on or off the pathways. And depending on if you knock them out or if you activate it, it turns on RUNX. So FGFR, there's a mutation here. This turns on the whole system. RUNX goes up and cells turn to bone. Twist actually negatively regulates this. So if twist is knocked out, there's no negative feedback. So it turns on the system. RUNX tells the cells to turn the bone. And this is in those syndromic pathways. So when we think about syndromes, we think FGFR and we think twist at this point. It's a very simplified version. And over the last couple years, this is what genetics looks like now. So we see FGFR and we see RUNX and we see twist in here. But now as we get further and further into the genome and specifics and running whole genomic sequences and figuring out what these things do, we start noticing that there's a ton more different genes, different areas that are involved in this. And so this is a field that's just exploding about what actually causes these sutures to fuse. The pathophysiology of this is Virchow's law, which I talked about, started back in about 1851 when he described how the pattern forms if the skull is fused. So I think the easiest one to talk about is sagittal synostosis. So that's the growth plate on the top of the head. And if the growth plate on the top of the head fuses together, then the 2 parietal bones can't split apart because they're basically one bone. So as the bone grows, as the brain grows, it's going to push the skull looking for more room forward, and it's going to push it posteriorly, and it's not going to push it side to side. So Virchow's law is when sutures fuse prematurely, skull growth decreases perpendicular to the axis. So the axis is front to back, so it doesn't grow side to side, and the growth increases in the plane parallel to the fused suture. The brain's looking for room. It has other open sutures, and it's going to try to find it. When you talk about bicoronal, so now there's no growth from side to side, so now there's no growth from front to back because the suture's fused across here. So there's no growth perpendicular to it, and it fuses and it will become wide and short. And so same idea here. It's just you have to decide what the suture is in the opposite direction it can't go. And this is what he was talking about back in 1851. This is when we see patients in clinic, we can look at their head, we can look at their head shape from across the room and say, I think you have sagittal synostosis, your head is long and narrow. I think you have trigonocephaly, it's triangular in the front. I think you have unicoronal synostosis where one eye is pulled up over the other one. How do these kids present? This is a kid who's 2 weeks old, and the head shape is by far the most common. We get words like abnormal, we get words like asymmetric, depending on what it is. If it's the sagittal suture or the metopic suture or both sides, sometimes it is symmetric, but it's abnormal. If it's one of the lambdoid sutures in the back or one of the coronal sutures in the front, then it's going to be asymmetric because one side grows normally and one side doesn't. But most of the time, kids are born with this. And so when you talk to parents and say, hey, who was the first person who noticed and when was it? Most of the time it was my pediatrician at my first week visit, or we noticed it when the baby came out. And then people look at it and say, well, is this going to grow out? Does it have a typical pattern? It's up to pediatricians and primary care providers to recognize this early and that it's not just molding from the birth. And so this is where education of primary care providers really helps, because oftentimes we can do things differently in younger kids than we can in older kids. If they get older and if they've increased intracranial pressure. So this is a small amount of kids who didn't get diagnosed when they were smaller, they weren't treated, and they happen to have a brain that continues to grow past the size of the skull that needs to be. So the skull is too small, the pressure increases, you can get headaches, you can get visual changes, you get other things like that. But the most common thing is an abnormal head shape as a baby. It's picked up with patterns. This is a kid who's 1 day old, and you can see that the head is triangular in shape. The eyes are closer together. This is metopic synostosis. So the suture down the center of the forehead, the skull can't grow out wider. The eyes can't grow out wider because it's fused together in the middle. And this is what it looks like even as early as 1 day. And these were astute pediatricians who said, I know what that is. Let's call neurosurgery. We don't do surgery on them at a day old, but let's call craniofacial surgery, neurosurgery, and plastics and plan on how they want to follow this and how they want to treat this. So it's all about patterns that you'll see. It's usually present at birth. It usually doesn't get better because it doesn't matter how the baby lays. It doesn't matter if you put him in a helmet. That suture's fused together and those bones are stuck. The brain can't push it out. Sometimes they have other syndromic traits. You'll see with some of the syndromic ones, they have hand and foot abnormalities. They have face abnormalities. Their midface may be pushed back. They might have a bigger jaw. They might have a smaller jaw. They could have ear abnormalities. They could have heart and lung abnormalities. Depends on what syndrome it is. It depends on how many other body systems might be involved. As we get past that, we said, hey, the main thing we see is going to be a pattern. The head shape looks different. Can you identify it? We also can use imaging. We can look at some measurements, which are sort of specific to certain sutures. So cranial index is essentially the cranial width divided by the cranial length. The normal percentage of that is between about 75 and 82% for people who have a normal head. If it's elongated, like in sagittal synostosis, it's going to be skinnier and from side to side and longer from front to back. So that ratio goes down. And so you start looking at cranial indices about 68%, somewhere in that range. If it's brachycephaly and short like this and bicoronal synostosis, that's going to get closer to 1 because the head is almost as wide as it is long. It's not a great measurement, but it is something to at least document up front to see how the head grows in one aspect as after they get surgery to follow. The frontal angle is another angle mainly for metopic craniosynostosis when they have that triangular forehead. If the angle is really acute, they might have metopic, or it's another way to measure it as the skull starts to widen out or as you correct it to sort of follow with some measurements. We're now looking at 3D imaging to look at what the cranial volume is, how big is the brain, different areas, 3D photographs where you can take a photo and it translates it into a 3D model. So better ways of measuring these kids before and after surgery. So that's where the photography comes in. We also do get x-rays sometimes. 3D CT is the mainstay, which has low dose these days. It's a quicker scan. Radiation dosage is way down, so we get 3D CTs. MRI is used in the syndromes, looking for things like hydrocephalus or other brain abnormalities, but this we're mainly looking at bones. And these are all x-rays that are different. This is metopic synostosis. The eyes are close together. They're pointed inward. Sagittal synostosis, the head is long and skinny. You can actually see the coronals and the lambdoids open here. Bicoronal craniosynostosis, no line in the front. Look how short this head is. Unilateral synostosis, this area fused together so the forehead couldn't push out because it's fused. This side's the normal side. That's a normal eye. That one's retruded. And then lambdoid synostosis, where the back of the head is flatter on one side and more pronounced on the other as the brain is looking for more room. Treatment involves many different teams depending on how involved the patient is. Some of the single suture kids are normal otherwise. They have a fused suture. We do surgery on them. We follow them, but their overall development is fine. They can feed, they can talk, they can eat normally, they can do normal things. If it's a syndromic kid or other things, then we get a whole team involved. And these are many of our team members here at Vanderbilt Cleft and Craniofacial team. It involves family medicine, pediatrics. These are people who actually see these patients first and have to recognize them out in the community for the well child checks. Physical therapy, occupational therapy, plastic surgery helps in the OR for the cranial vaults, neurosurgery as well. ENT, often these kids have airway issues or ear issues. Ophthalmology, if the eyes are off and they're not level, sometimes they need to do surgery on the muscles of the eyes to straighten those out or follow them. Anesthesia, many of these kids have airway issues as well, so it's a more complex anesthetic in the operating room. Critical care, dental, an orthotist, many different things, social work, and also feeding, nutrition. Many different team members have to take care of these syndromic kids. So why do we treat? In most cases, the skull growth would be adequate, even if the head shape is abnormal, but the child is left with an abnormal head shape and facial features. But in some cases, the restricted skull may not provide enough space for the brain. The brain grows normally, the skull is too small. It can result in clinical manifestation of increased intracranial pressure, which could lead to things like visual impairment, headaches, impairment of mental development, reduction IQ, developmental delay, things like that. The prevalence of this ICP has been estimated to be as high as 20% in single sutures, and with syndromes and multi-suture up to about 60%. New studies may say that the ICP could be over 40% or high in 40% of patients with untreated sagittal synostosis, but these are older kids who weren't treated, so it may be a little bit of a bias of the patient population. Regardless, the main reason to do this is to change the skull shape, make a more normal head shape, and potentially give the brain more room if they would be one of those kids that could have increased intracranial pressure. This is a syndromic child. This is the inside of the skull of the frontal bone right here. And you can see that this kid was a little older, and these are the imprints of the brain, the sulcine gyri, so the curves of the brain that's pushing on there. This is the sinus that right down the middle, a vein underneath the dura. You can see that the brain did have pressures pushing against the skull, and as the skull formed, it actually took the imprint of the brain. So the treatment goals are to restore a more normal head shape and mitigate the risk potentially posed by increased intracranial pressure. Simple synostosis. It's simple in the sense that it's a single suture and it's a non-syndromic. These are the words that we use to describe it. The sagittal sutures we talked about, long and narrow. The word for that is scaphocephaly. The coronal, if it's one of the sutures, it's anterior plagiocephaly. Bicoronal is brachycephaly, meaning short head. Metopic, trigonocephaly, triangle head. And lambdoid is going to be posterior plagiocephaly, which you have to differentiate from deformational plagiocephaly, which is the condition when kids are young, they lay on one side of the head over the other whenever they're younger. Because of the pressure, they're not sitting up yet, they're too young, and the pressure from laying on that side pushes some of the back of the head forward and to make it flat. That's the non-surgical treatment, non-surgical condition, which up to 50% of actually kids these days can have, which is very different than the surgical synostosis, which we're talking about. Sagittal synostosis, we're going to go through the main examples here. It's the most common single suture that's fused in about half, a little more in males. We get scaphocephaly. So here's a picture. This is a 3D reconstruction of this kid's head. You can see that the sagittal suture on the front of the head is fused. This is what the growth plates are supposed to look like. That's the anterior fontanelle. In doing so, if we remember Virchow's law, the brain can't go side to side because these are fused together. So it grows front to back. So you get some more frontal bossing, which is in the front. You get a prominent occiput where it gets long and narrow in the back, and you get a skinny parietal width here. So this is what they look like from the front: tall and narrow, long and skinny, a little more prominent in the front. This is very common. This is what the textbook sagittal synostosis looks like. How do you treat this with surgery? We'll go into a little detail later. You'll have a lecture on this as well. There's some minimally invasive craniectomies where we just take the strip of bone out if they're young enough over where the suture is. And then we either use springs to push that apart and keep it open, or use a helmet to help guide the growth so that that bone just doesn't fuse back again. Those kids have to be young. Or a craniovault reconstruction where we actually do surgery. We expose most of the head here. We make cuts on the side of the head where we then outfracture the bones to the side. We decrease the diameter from front to back, use some sutures, sometimes some absorbable plates, sometimes just out fracturing it, and we physically change the shape of the skull in the operating room. I'll show you a picture of that later. Coronal was the second most common, maybe metopic is nowadays, a little more in female. It's a unilateral coronal. If it is here, you get this thing called anterior plagiocephaly, where one side of the forehead is retruded. The normal side is actually the side that pushes out, and most of the people pick up and say, this side looks like it's pushing out. It looks like he's Popeye. It looks like he's squinting. That's actually the normal eye. It's the other side that couldn't grow out to match it. They get this description called a harlequin eye, which is back to these sort of masquerade masks. And if you look at this eye, the sphenoid bone is behind it. It looks like the eye where it's pushed back and tapered in that way. So that's the harlequin eye. The plagiocephaly, you can see this suture is fused. This side can't grow front to back, so it grows a little wider to the side. This side compensates for it for brain growth, and you get a head that's curved and pushed back on one side than the other. The eye is pushed up, the forehead is pushed back, it just can't come out. Again, if it's young enough, an endoscopic assisted craniectomy, we can take that piece of bone out, let the brain push it out from the inside, or a frontoorbital advancement where we physically take the frontal bone off, we take the top of the orbits off, we push the side that's back up towards the other one and make it even, and then we reconnect it with either sutures or absorbable plates. Bilateral coronal is a little different. This is the one that we see mainly in syndrome. So if the kid has bicoronal synostosis, they're going to get some sort of genetic workup. Brachycephaly is the word we use. You can see the coronal sutures in the front, one on each side are fused. It's open to about there, and then it's fused on both sides. Brachycephaly, it can't grow front to back because these bones are fused, so it grows side to side and tall. The brain is looking for room, and that's brachycephaly. You can also see that it looks like the eyes are more proptotic because not only is the forehead shallow, but the orbit is shallow as well. Again, if you get these kids early enough, you can do an endoscopic assisted, remove these strips, put them in a helmet or put springs on, let the brain do the work, see if that pushes enough. You're trying to get brain growth overall from front to back, or a frontoorbital advancement where you take the bone off in the front, push it forward, or sometimes if they're old enough and the back is really flat, you can actually remove the bone back here, put some distractors in, which you can twist from the outside, and it pushes the posterior craniovault backwards. You can see how short it is back here, and we're trying to get brain growth early on to decrease the intracranial pressure. As we mentioned, the rate of increased intracranial pressure goes up the more sutures that are fused. So the rate of a bicoronal kid, if he's not corrected with increased pressure, is much higher than a single suture. Metopic was about 15%. It's increasing now. We talk about trigonocephaly. So look at this kid from the top. Look at this CT scan. The metopic suture is fused. The frontal bones couldn't separate and push forward. The eyes are closer together. They couldn't separate as well. And you get this very triangular shape where, in fact, when you look down upon the head, you can see the orbits from above. This is that frontal angle. The more acute it is, the more severe it is. And trigonocephaly means triangular head. They get temporal narrowing. The temporal bones are here. The areas on the side, you can see how narrow that is. And hypotelarism, so the eyes are closer together because the bones in the front of the face couldn't spread out either. Again, if they're young enough, you can take the strip of bone out, either put springs or a helmet to help guide that. Frontoorbital advancement, the same thing. Take the forehead off, take the orbits off. They come off looking like a triangle. Make them more rounded, make the orbits match that, put them back on, reattach, and close the skin. A metopic ridge I put in parentheses because this doesn't require surgery. We see this often. This is a child with normal eyes. You can see where the orbits are. There's nice space in between. The forehead, when you look at this, is rounded. It's nice and rounded. It's not triangular compared to that last one. The metopic suture is fused, which happens within the first year of life. And sometimes there's just a little more bone deposit on that. This does not require surgery. It has a round forehead, normal eye placement. No treatment is needed, and this will actually become less noticeable as the baby gets older, the skull becomes thicker and the scalp becomes thicker. So this child is very different, and this scan is very different than looking at this scan here, which is very triangular and is synostosis compared to a ridge, which does not require treatment. Lambdoidal suture. This is the least common. We see maybe one or two of these a year here. The lambdoidal suture is in the back of the head, and so it produces this posterior plagiocephaly, not to be confused with deformational posterior plagiocephaly. In this situation, this area in the back can't move forward and back, so the other side compensates. You can see how much more growth in the skull there is on this side and back here because the brain is looking for room. Look at this side compared to this. Look at this side compared to this. And unlike posterior deformational plagiocephaly, if you lay on this side of the head for too long, the whole area goes up. This one, it's almost as if it's stuck. So this side is actually smaller than this side. And you'll see what I mean. And the difference means, does one patient need surgery? And does one patient just need to get older, sit up more, do more tummy time, get off that side of the head? If you catch these kids older, or younger, which is hard to do because they often are confused with plagiocephaly and then they don't get better, you can do an endoscopic assisted, but most of the time it's surgery to remove both sides, mainly take the good side, put on the bad side, but equal these out so that the more prominent side is smaller and the flatter side gets bigger. Syndromic synostosis is a very different diagnosis, and we counsel these parents very differently because these are passed on mainly through families. They also have other organ systems that could be affected. Their development is oftentimes different. They often require multiple surgeries, not only on the skull, but also on their face or on their jaws or on their fingers or their toes. So we have to counsel patients very different. And there's, as I said, the craniofacial team follows these patients because they require very different care of all aspects of life. The main two are Cruzon's and Apert syndrome. These are the most common. They mainly have bicoronal craniosynostosis, but they can have other ones. Apert syndrome also has hands and feet where they have syndactyly, which means that the hands and feet are fused together. If you see a child with bicoronal craniosynostosis and fused toes and hands, it's likely Apert syndrome, but these are some of the other common ones. Secondary synostosis can be seen for multiple reasons. We talk about hydrocephalus. If there's not as much of a driving force pushing the brain out, the sutures can come together and stick. The metabolic disorder, rickets, hyperthyroidism, bone growth disorders, congenital malformations where there's not that drive. Sometimes pharmacologic agents, valproic acid, phenytoin, can cause suture fusions as well. This is a 4-year-old or a little less at that point with rickets. And he likely had sutures to begin with. You can see some. And then over time with the rickets, he started fusing these off. And so everybody with rickets gets a CT scan here in our clinics. And if they have synostosis, they come and see us and we decide what to do with it. But that's why this child is a little older compared to the babies that we see. Positional plagiocephaly, this isn't really craniosynostosis, but if we're doing an overview of skull deformities and in pediatric skull issues, this is the most common by far. And this one is in parentheses as well because it doesn't require surgery. And unlike lambdoid synostosis, where the skull can't grow front to back in this area and this whole side is smaller than the other one, positional plagiocephaly is this sort of parallelogram where one side is laid on more than the other, that whole side get pushed forward. So you see flattening on the back, you see that ear go forward, you see that forehead go forward. And it's almost as if they laid on this side a little more in the skull and the sutures are open enough that you do that and you sleep half your life at that point and it pushes things forward. And that's exactly what happens. So we did a study here looking at CT scans from kids who got basically had traumas and looked at them from very young, so 2 to 5 months of age, all the way to teenagers. And if you look at this, about 40% of children below 5 months have some aspect of positional plagiocephaly. So it's almost half. I can't think of many other things in medicine that almost half of the overall population has. So this is really, really common. And this is the time where babies don't sit up. They don't lay on their stomach. They tend to choose one side or the other. As they start sitting up, as they do tummy time, as they spend more time in their parents' arms, sitting with better head control, the rate of plagiocephaly goes way down. And by the time you get to teenagers, the rate really, when we look at all comers, and this is even before we really treated plagiocephaly very much, it's about 10%. The other reason that plagiocephaly is so common is because kids, because of SIDS, are now being told to go back to sleep, so sleep on their back. And so when kids sleep on their back, sometimes they choose one side or the other, and you get positional plagiocephaly. So this generally is not present at birth, unlike craniosynostosis. It's a parallelogram deformity. That whole side of the head is pushed forward. The back pushed forward, the ear is pushed forward, the eye is pushed forward. So everything goes forward. This doesn't require surgery. And it is mainly fixed by repositioning. And if there's other things like torticollis, that the kid's head can't go to one side, some physical therapy to get that range of motion, in really severe times, sometimes we talk about helmets. I'll show some studies related to that. But the main thing here is trying to get the kids off of that side of the head, make them sleep on the other side as best they can, get them up on their stomach as soon as they can. And when they're in their parents' arms, make them look the other direction. And over time, the brain will push that side back out and equal things. So this is the difference. Deformational plagiocephaly, parallelogram, everything goes forward. Lambdoid synostosis, this can't grow front to back, so the ear actually comes backwards, the forehead comes backwards, and this side is smaller than this. The other difference is the skull base is tilted. So this patient has right side lambdoid synostosis, and if you look at the back of the head, the ear is down. In positional plagiocephaly, it's equal across the back. So when you look at them from the back, the ears are symmetric on the skull base. This is a giveaway as well. So this is important to know. Does this patient need surgery? Do they not? Can we get them early for something smaller? Or does it just not get better? And we look back and say, yep, that's synostosis and not plagiocephaly. Deformational plagiocephaly, treatment, repositioning, get them on the other side if they can. Tummy time as soon as they have head control, get them up. Physical therapy if the range of motion, their neck isn't great, treat the torticollis. You'll probably, or you may know somebody who's worn these helmets for plagiocephaly. They cost somewhere about $2,000, give or take, depending on which part of the country we are. You wear them about 23 hours a day for 3 to 6 months. They can get pressure areas. You have to adjust them at the helmet clinic so that the head can still grow. So there's a place that rubs, and you have to get them in early, because if the kid's a year old, most of the growth is done. You probably don't get as much bang for your buck or correction as you would whenever they were picked up at 4 to 6 months. And they also showed that there's a study in 2015 that shows that parental guidance and education about plagiocephaly actually helps prevent it. So if parents are aware of this whenever their kids are born, then they pay attention to it. They put the kids on the other side, they can adjust, and they can actually prevent this. Do helmets work? Some studies say yes, but the main thing is they work better in patients with torticollis, so their neck is stuck in one direction, so they can't turn their head, with delay, so they're not sitting up as much, they can't do tummy time, or really severe deformity where the whole head and face is pushed forward. There's a randomized control trial in Scandinavia where they randomized people to helmets and no helmets. And the caveat here is that the very severe patient, so the one with the face pushed forward with torticollis that the head can't turn, with syndromes where it's occluded, and if all the other patients were randomized, then it comes out the same way with the helmets and just physical therapy, or just tummy time and just moving the head, repositioning. So in most of our patients, unless they're delayed, unless they have a neck cervical problem where they can't turn their head, or unless they're severely deformed with their face, then we actually don't really use helmets that much. We talk about repositioning, some physical therapy, tummy time, and things like that. So let's get on to surgical treatment for the second half of this. So what do? We talked about a couple different options. We talked about the active reconstruction, which is considered the craniovault reconstruction, where we physically change the shape in the operating room. This patient has sagittal synostosis. The suture down the center of the head is fused. It's long and narrow. This is that pi procedure that I talked about, because the cuts look like the Greek letter pi when you're looking at it from the top. There's a cross, there's the one side on the bottom, there's the other side. And basically we make cuts down the side here, around here. We outfracture the sides to make it wider. We bend these bones out to make it wider. We cut a piece of bone out from the front. We push it together and we suture that or wire that together, put a plate there. So we take something that's long and narrow, we open it from the side and we push it front to back so you can make it wider and shorter. You've changed the shape in the operating room. That's what an open reconstruction is. For metopic or bicoronal, we're talking about fronto-orbital advancement. That means the frontal bone and the orbits. Look at this child's head shape. That's very triangular. When we see it in the operating room, looking at it from the side, looking at it from the front, this is looking at it from the top of the head. The eyes are up here. The back of the head is down here. And we pull the skin down to where the eyes are. That's the top of the eyes from the top looking down, all the way to the back of the head. We make cuts in the frontal bone here. We make cuts in the orbit, and we actually remove this piece of bone here. And then we widen it out and put it back on. And so you can take a bone that's really narrow and triangular, make it wider, put it back on, and now you have a change in the operating room. As the kid gets older, you can see the eyes are wider. This kid looks cross-eyed, not because the eyes are any different, but they're closer together, so you can't see the whites in the middle. You can see now how it's widened out, how flat his forehead is, and how good he looks later on. So when we talk about a cranial vault reconstruction, if it's for sagittal synostosis, it's mainly for the top of the head, the sides of the head. The lambdoidal is mainly for the back, and the bicoronal and metopic is usually for the front. We have minimally invasive options if we get these kids young enough. What that means is we basically recreate the suture. We release the suture. They have to be young. You have to let the brain drive correction. So you basically give them their growth plate back and then let the brain do the work like it was supposed to. And you use the helmet to guide the shape. So in this case, unlike with plagiocephaly, the helmet is necessary, because if you just take the strip of bone out the middle like they did in the 1800s, they get a little correction as the brain grows, but then the sutures fuse back together. For example, in sagittal synostosis, if the head shape is too long, you take the suture out of the middle of the head, you put a helmet on that's more snug in the front and in the back. You leave some room on the sides. As the brain grows, it can't go front to back. So you guide it, it'll grow out to the side and sort of fill in the helmet where you want it to go. In the metopic, where it's triangular, you put it more snug on the front. In the center of the triangle, you leave room on the side of the front, and you let the brain push it forward. So it's sort of a passive reconstruction in the sense that you're using more physiologic brain growth with this. The good to this is it's a smaller incision. We've published on things about less blood loss. We talked about less blood transfusions, shorter ICU stays. In fact, quicker recovery, even decreased cost because of ICU stays, the stays in the hospital. The bad is, though, that there's age limits to this. And if the kids are too old for sagittal synostosis, above about age 4 to 5 months, for metopic and coronal, where the orbits of the skull base is involved, it's got to be younger, because that becomes too thick and the eyes won't widen. So ideal somewhere around 3 months of age. So you got to get to the pediatricians and the primary care docs to recognize this at the 2-week or the 1 month visit, or at the latest at the 2-month visit, so they can get to see us and we can give families options. Otherwise, if they show up at 6 or 9 months, we can only offer the bigger operation, no matter what the patient has. They do need helmet therapy. And so down here in Nashville, the only helmet therapist that did post-op helmet therapy, there's many do plagiocephaly, but only post-op, was here in Nashville. And we serve a big area that spans the state and up into southern Kentucky and northern Alabama and in Mississippi. And if the family was from 5 hours east of here in East Tennessee, they probably weren't going to make a 10-hour round trip to get their helmets adjusted every 2 weeks. And so the family location was part of the issue, how close to the helmet center there were. And so what we ended up doing was talking to people in Knoxville, a helmet therapist out there who is trained by our person here. So now we can offer these things in East Tennessee and give these options to the patients in those populations as well. So it's great. It's a smaller surgery. It's a little easier to recover, but you do have to have an age limit of helmet therapy when it comes down to it. What does that look like? In the OR, here is sagittal synostosis. Again, frontal bossing, occipital narrowing. The sagittal suture's gone. His head is tall, is long and thin. This is actually the kid post-op day 1 without swelling. Here's the incisions on the top of the head, right in the front, right in the back. And we take this piece of bone out right in the middle where the suture was. You can see when he first got his bone scan or his helmet scan, it was wider in the front. It's narrower in the back. Look how much wider it got over time. This is what it looks like when we use the scope to go underneath the bone to separate the covering of the brain down here from the underside of the bone to make sure there's no bridging veins or any blood vessels. This is the covering of the brain. That's the bone. We separate it with the endoscope. We look down there, and then we take scissors to cut that piece of bone out. And that's what the endoscope is used for, just to visualize, to make sure we don't put tears in the dura, covering the brain, or to make sure there's no bleeding vessel in it too. And this is the child when he's about 3 years of age. You can see how nicely his head is rounded out. You can see now in the back of the head, it's wider than the front, where here he's basically all forehead. This is what we want to see looking forward. Metopic, we can do the same thing. This is a young child. He's about 10 weeks old, trigonocephaly, temporal narrowing, hypotelorism. His eyes are close together. He's got a triangular forehead. You can see it on the CT scan. See how close together the eyes are. Essentially, you should have the width of an eyeball in the center of the head here. These eyeballs are definitely wider than the area in between. You can see on his scan immediately post-operatively, that's how he looked, very narrow. And now his head is widened out in the front, nice, round, nice and flat. That point's not there. And the forehead is rounded out as well. This is after we took the bone out. You can see that that's the scalp from underneath. This is the wedge of bone that we took out, which is right down the center of the head. You have to get all the way down here between the eyes, which is where this area is. And this is the covering of the brain underneath. So we're visualizing to make sure that we completed from the fontanelle all the way down to the nasofrontal suture to release it, so that when the brain pushes things, we got the whole suture released, and it's not going to get caught up at the top or the bottom. Here's this kid when he was much older, a couple years old. Again, look how wide the eyes are now. His forehead is nice and flat. You can see how nice and round it is. So a good result. When we talk about these, there's many studies going on about open and minimally invasive and the time frame. That's where the neuropsych and then neurodevelopment comes into play. We're looking at future studies. What does the future hold for craniosynostosis? How do we diagnose this stuff early? Can we diagnose this intrauterine? And if we can, is there some sort of genetic marker that we can use? Is there a genetic treatment? Is there a drug we can use? Is there some sort of genetic modification we can do to try to reverse something early on if we know that the patient has this before the sutures fuse? Can we recreate the suture intrauterine? Can we figure out how to get this earlier on? Not yet, but maybe someday. Outcomes we're looking at. Is it just cosmetic outcomes? It's not, but what's the best way of looking at cosmetic outcomes? 3D models, cranial vault volume. What do we do with that? Is there a way that we can use smart technology? Take a picture at the pediatrician's visit, and AI can tell people, does this look like synostosis or not? So they can put a scan in the chart, and AI says, we think this is synostosis. Maybe we should get an x-ray. Maybe we should make a referral, things like that. Neuropsych and then neurodevelopment. That's the main focus of a lot of research here, is what happens to the brain. Is it better to do this operation earlier on? Is it better to do it later on? Is it better to do a cranial vault reconstruction? Is it better to do a suture release? Nobody really knows the answer to that right now. And from the kind of primitive studies that we have, at this point, it looks like there's no major difference between them. So the only difference we have is you should get something done, because we think that if you don't, that could cause problems in the future. But as far as which ones, I counsel families that essentially both are equal. Both have good cosmetic outcomes, both have good neuropsych and brain outcomes. So it's basically up to the family. Do they live close enough? Do they want to deal with the helmet for months afterwards? Do they like the risk benefits according to the big procedure, the small procedure? But at some time, we're trying to figure out is which stage should we do it? How does that affect what the outcomes are? And is there a better time to do it? There's also imaging. Is there a way that we can predict which patients will get brain issues and which won't? So if only 80% or if 20% of them could have increased ICP, but 80% don't, and their head shape is abnormal, is that enough for some parents to say, well, I would do surgery anyway, or you know what, that's okay. We can handle his head being long and skinny, but we wouldn't want to have him do surgery if it's not a brain problem. So we're looking at advanced imaging, MRIs, fiber tracking. How does the brain connect? Can we see evidence of brain issues before we do surgery? Do they correct afterwards? Are there certain patients that are more likely to fuse again? So you do an operation on them, it fuses again, you do a second operation. Why are some more severe than others? So it's not just neuropsych and outcomes and cosmetics, but can the imaging help us out? Can the MRIs do it? And there are studies going on right now to try to figure that out. Genetic markers and treatment. Who is severe? Who's going to pass this on? Who do we think is going to have a secondary problem? Who's going to have more of a brain issue? Who's not? These are things we'd like to know up front to counsel families. Or is this just saying your kid's going to have one operation, he's likely to heal from it, he's likely to go on and continue on? Parental factors. Who's going to get this? Is there something that either the father or the mother has that's going to cause synostosis? Can we counsel about that? We're looking at global incidences. This is a treatment that's mainly done in Western countries. It's picked up here. It's mainly treated. You can see that it's a big operation on a small kid, so it needs a lot of resources, needs anesthetic, generally speaking, a lot of blood transfusions or the capability of that. It needs ICU care. It needs things that sometimes in other lower income countries, They don't have that. Or everybody's overwhelmed with traumas and hydrocephalus and tumors and other things that synostosis isn't even on the radar. So what is the global incidence of synostosis? We started looking at that here with a group from Vanderbilt, one of my partners, looked at this, but is there a way to figure out, are those patients being passed over, or is it just not in that part of the world? ICD-10 encoding factors is something interesting that my plastic surgery colleague and I have been working on. Is it up to this point, the ICD coding was essentially craniosynostosis in general. As you saw, they're all very different. And sagittal synostosis looks different and is treated differently and might have different outcomes than metopic craniosynostosis. So why are they all coded the same? And we're trying to figure out, and we're deep into this, is can we have a separate code for sagittal synostosis versus lambdoidal synostosis versus coronal synostosis, so that as we look back at these patients in research, we can pull them out or we can separate them and see what their outcomes are. And so that's what this clinical staging for synostosis is. Can we separate them and look back? Can we look and say, your imaging tells us this, you get so many points for that. Your genetic marker tells us this. Your neuropsych tells us this. Your overall head shape tells us this. That puts you in a severe category. So maybe you're more likely to have brain issues, neurodevelopmental issues, or need more operations, or your score is low. And so maybe you don't. It's probably one operation, you're done. Now we're trying to figure this out. Also, parents want to know, as you're talking about a 3-month-old getting their head operated on, can they play sports when they do older? Can they do normal activities? We surveyed a bunch of patients who were in their teenage and 20s and said, hey, what sports did you play? Did you have worse concussions or mainly worse catastrophic brain injuries? And it turns out they occasionally got concussions, just like people do without synostosis surgery, but there weren't any large skull fractures or subdural hematomas. And so when we counsel these families, we think that if this all heals great whenever they're a youngster, we think they can have a normal life and play sports even as much as football and hockey. So we're starting to look at what does this look like when they get older. We're looking at ways to minimize blood loss, different medications in the OR to help them clot. We're looking at caregiver stress in patients' families. So how does this affect the family? They just had a child. Now you're talking about doing surgery on them within their first 2 months of life. They have to deal with having a newborn, having surgery. Does one type of surgery predispose the caregivers to have more stress? Is there a certain stressful part that they are dealing with? Can we help that? Can we give them resources to help them get over those stressful situations? So these are things as well that goes beyond just the cutting of the skull, reformatting, reshaping the head, but trying to figure out the whole future of genetics, imaging, what the patients can and can't do, how to make it a safer surgery, what it looks like globally, and how this impacts the parents as well. So that's a whirlwind tour of synostosis. It's nice you guys have another bunch of lectures coming up about those in detail. I'd like to thank my pediatric plastic surgery colleagues, Dr. Kevin Kelly, who was here at Vanderbilt for, 25 or 30 years, but for my first 5 years, and he was my plastic surgery colleague through my first 5 years doing these craniofacial reconstructions, seeing patients in clinic, teaching me techniques, and doing these patients together. And then my current colleague, Dr. Michael Galinko, who's involved in many research projects with me, and he's been here for my last 4 years, who's in the operating room as well, who's doing research with me, who we're seeing patients together. But they're the main two plastic surgeon colleagues who we do these cases together in the operating room. So this is a team aspect, and these are the two main guys who I work with on a weekly basis. Thank you again for inviting me to this talk. Thank you very much. It's been a great honor that you chose me to give this overview. If there's any questions, I think you recorded this. That's why I put so much detail at the beginning, especially with all those genetic things that you don't have to learn or even think about from one talk. My email's on there. And so if you have questions, just let me know.
Yeah, thank you so much. That was such an awesome talk. We're glad that you were able to speak with us tonight. I was just wondering if you could speak a little bit about how you got involved in global neurosurgery and specifically about craniosynostosis that you've seen globally.
Yeah. Global neurosurgery was something that I got into during residency training. Each residency has a little different time frame as far as sort of research years, elective years, career enhancement years, whatever you want to call them. But neurosurgery now is 7 years across the board. And so some of that time is sort of personalized. And so I was able to go away and get in touch with mentors who did global neurosurgery during my 5th and 6th years of research, or 5th and 6th years of residency. So we got involved early, and we try to get our residents involved. If there's people who are interested to get projects from home here, try to link them up with maybe fellowship opportunities or grant opportunities. And we've had residents who have taken even a whole year off. My pediatric colleague here, who we hired back, was away for a year in Africa and traveling around, looking at things like incidence of different disease pathologies overseas, and realized that things like craniosynostosis is sort of way down the line as far as what most people treat. So it's traumas, it's spine issues, it's a lot of hydrocephalus, it's a lot of strokes, even though it's not a neurosurgical disease. Sometimes there's not neurologists around, and a ton of hydrocephalus and spina bifida, things like that. So what's nice is that global neurosurgery now, before was sort of different people kind of on their own, getting involved in places with ties overseas, with engaged local providers, because the people there have to have a need. They have to want to be involved. They're the ones who really run the show. And we're just there to kind of help out and help educate as they continue to build training programs and populate neurosurgery out wide. But sort of organized neurosurgery in general now has seen that need and has brought things together at the more kind of organized level between national meetings, national organizations. And that really helps. So we know who's doing these things. There's more funding, there's more involvement, there's more education. Zoom, believe it or not, even though COVID has been horrible, the reason we're probably doing some of this is because Zoom has been much more around, and the virtual teaching is much more common. And so we've done courses overseas for people who otherwise wouldn't have been able to get course and be educated. And so there's a lot of virtual learning going on as well. So I think it's something that global medicine in general is becoming more frequently noticed, and it's also being more noticed as a viable career. I think before it was kind of, well, that's great, you do this, but what are you doing at home? And now people realize that with education, if it's part of your career, if you're writing about it, if you're making a lasting connection, if you're collaborating, this can be part of your actual career as well. So it's evolved quite a bit over about the 8 or so years of my practice, plus the residency and stuff before.
Yeah, that's really interesting, Dr. Bonfield. If I can ask a question, I was interested, you were showing some of that data about the helmet therapist and what you guys did in training someone in Knoxville. Is that common, problem that there are a limited number of helmet therapists geographically in the US?
Yeah, there are. Fortunately, most of these procedures are done at major children's hospitals, and most of those children's hospitals are based in an urban area that has things like, if we're doing spine surgery, spine bracing or scoliosis bracing or things like that. And some of that crosses over to helmet therapy as well. And positional plagiocephaly is so common, the helmets that are done for the laying on the back of the head part, that people are familiar with helmets. The issue is that they use that in a different way. They have to sort of think ahead. That's just sort of one thing. And how does the incision affect it? How does the head evolve if you've removed some of the skull? How is the interaction with the surgeon back and forth with me? Because I see these patients every so often, but it's that helmet therapist who's kind of running the show. And if they think that things aren't going quite as well as they want, they'll send me the image. They'll call me up on the phone and say, I think we're growing out in this direction. Can I adjust this? Do we need a second helmet? Do we need a third helmet? And so I think it's more just comfort level. And it's something that can be learned just like everything else. And we just happened to have somebody who had done it here and actually who does a lot of the courses nationally. So when I got here, I felt very comfortable with him. And he was happy to train somebody in the same company in a different center to help out with that. And so I know, at least in our area, I think there's one in Birmingham, Alabama, which is about 3 hours south of us. Memphis is about 3 hours to the west. I think they have one there too. So it's sort of, if you have somebody within about 3 or so hours, you're doing pretty well. And most parents are somewhere in between that. So sort of the longest they have to go is about 3 hours. And most, if they get them young enough and they're motivated, they'll do that. Once you start getting past it, it's tougher. But these are things, and it's not just the helmet people, but it's about pediatricians and primary care docs to get them to recognize this stuff. Because before, they just kind of thought, hey, if it doesn't get better at 6 months, I'll send them into craniofacial clinic. and that worked for a while. But now that we can do smaller operations on younger kids, then we have to tell them, hey, if you have any question at 2 months, send them, and send me 10 patients that don't need an operation. But we get one that we can do earlier on, so I don't mind getting patients that don't need something. Just send us everybody that you have a concern about. So it's been a little different thinking standpoint about getting them in earlier than waiting and just seeing if things get better.
Yeah, very interesting. I mean, it almost sounds like bringing a little bit of global neurosurgery back home and thinking about that geographic access.
Mm-hmm.
So very cool. Laurel, did you have any other questions or anything in the chat? Yeah, I'm not
Sorry,
seeing Sorry, go ahead. Yeah, well, I'm not seeing anything in the chat, although there was one person who actually said they just saw a case of this today in the peds clinic. So nice serendipity, and maybe it taught them something that they'll be able to take back in tomorrow. If there are no other questions, then we'll go ahead and wrap up. But really, thank you so much for a really interesting talk, and we appreciate all the detail that you put in, because this is going to be a resource for future medical students and maybe even junior trainees. And we actually do have a pretty big global following of folks who use this in their preparation as global trainees. So you're contributing to our base, and we really appreciate that.
Yeah, I'm honored for you inviting me. Thanks for picking me out of the crowd there, and I hope that that this is what you guys are looking for. So I appreciate it, and good luck with your next few talks. They should be able to get in a little more detail. So I think it's great that you guys continue with themes as you go along.
Thank you
Definitely
so much.
Thank you.
We really appreciate it.
Yep.
All right, and with that awesome intro behind us, welcome to our Craniosynostosis series for management. My name is David, and I'm an education director here with the Medical Student Neurosurgery Training Center. And I'm just going to go ahead and share some introductory slides to kick us off here. All right. And apologies for the delay for those of you who tuned in at 8. We had a little bit of a technical malfunction there, but we are back up and running. So this is, again, our craniosynostosis block, our first block of the new year. And so we had our first session of overview last week. This week is our management session. On Valentine's Day, we'll be doing our journal club. And then we have our grand round session the week after that. So all of these will be starting at 8 p.m. Eastern on Tuesday. Tomorrow, we have a great webinar with Ryan, and it's going to be about spine trauma in Africa, where Ryan's going to be talking to a surgeon at Cornell Weill and discussing that in more detail. And that's, again, happening tomorrow night. And we also have the Neurosurgery Journey webinar, which is live every Thursday at 7 p.m. Eastern. And in fact, this Thursday, we have the neurosurgery preclinical perspective geared towards M1s and M2s who are interested in neurosurgery. So if you're an M1 or M2 and you want to learn more, definitely check this out this Thursday. And we have our Brain and Spine Injury Service fundraiser for military personnel, veterans, and patients. And we are really dedicated to supporting all of those individuals. Our goal is to raise $15,000 by February 15th. And so we're going to be posting some QR codes and some links in our chat. And we have more information on our website as well. So please donate if you're able. And we have our YouTube video library, which has recordings from webinars like this one, as well as previous ones. And we have over 10,000 subscribers on YouTube. Definitely check that out if you're interested, and be sure to subscribe. All right, and then we're just going to get started here with our esteemed guest, Dr. David Hirsch. Dr. Hirsch is a pediatric neurosurgeon at Connecticut Children's in Hartford, Connecticut. and he is an assistant professor of surgery and pediatrics at UConn School of Medicine. After obtaining his undergraduate and medical degrees at NYU's combined BA-MD program, Dr. Hirsch moved to Baltimore to complete his neurosurgery residency at the University of Maryland Medical Center under the leadership of Dr. Howard Eisenberg. Having developed a passion for pediatric neurosurgery, he went on to complete a pediatric neurosurgical fellowship at Le Bonheur Children's Hospital and St. Jude Children's Research Hospital in Memphis, Tennessee. His current interests include pediatric neuro-oncology, epilepsy surgery, and endoscopy. And Dr. Hirsch also serves as a faculty advisor for the Brain and Spine Group and the Medical Student Neurosurgery Training Center, and we are immensely grateful to him for all he does for us. So without further ado, Dr. Hirsch, the floor is yours.
All right. Thank you so much to David, and thank you everyone for the invitation to be here. Let me know if you're able to see my slides. There we go. Can you see me?
Yes, we can see you.
All right. I'm going to try that one more time and share my slides here. Can you see the slides?
Yep, we can see them now.
Okay. We'll give that another shot. So tonight, the goal is to talk about craniosynostosis management. I know that you had a great lecture last week giving you an overview of craniosynostosis. And so I'm going to move rather quickly through some of the introductory especially in the intro, but I'll stop at a couple of these to highlight some key points. I think you probably heard all of this last week already, but it's really important to understand the anatomy that we're talking about. There's two main fontanelles when we're born, one in the front, the anterior fontanelle, one in the back, posterior fontanelle, which close a bit sooner. And when we talk about craniosynostosis, we're really talking about premature closure of one or more of these cranial sutures, which are the growth plates of the skull. And essentially, if one or more of those close prematurely, you end up with very specific head shape abnormalities because the growth becomes restricted perpendicular to that cranial suture, but it continues at all the other sutures that are still open. And so depending on which of the sutures has closed, you'll end up with one of these several head shapes. And it becomes really important, when we talk about management, really the first step is making the appropriate diagnosis in a reasonable time frame. And I'll talk a little bit about why the timing is so important. And so pattern recognition, really picking up on some of these features and some of these phenotypes becomes really critical in the office. What you'll hear and what you'll find as you go through training is that in the vast majority of cases, we can make the diagnosis based on physical exam alone and recognizing these various head shapes. And it's really only a minority of cases where we need to go on to get some sort of imaging of the suture in order to see whether it's open or closed. So here you have a great example of a patient with sagittal craniosynostosis with restricted growth perpendicular to the sagittal suture. So you end up with a very long and narrow head with compensation in the front, frontal bossing, compensation in the back, occipital bulging. And you can see several examples of that here. With metopic craniosynostosis, you have restriction of growth perpendicular to that metopic suture. So you end up with a very narrow forehead, and the phenotype is described as trigonocephaly because it really looks like a triangle from the top down. And you see you can have a very narrow forehead with hypotelorism. The eyes are close together. You have a very prominent angle between the frontal bone and the orbit. There's several different examples of that here. Each one of these cases represents a patient with trigonocephaly. And we really have to differentiate that from benign metopic ridging, which is a condition that we see very often because it can happen when the metopic suture closes normally. And the metopic suture is the exception. It's the only suture that does close normally during infancy, usually between 3 and 9 months of age. And when it goes through that closing process, you can develop some ridging along the suture. This top photo is a picture of a patient with metopic ridging. You can see that although in a frontal view, you would see they have ridging along that midline ridge, along the midline metopic suture. From a top-down view, they really have an otherwise normal head shape, as opposed to a patient with metopic craniosynostosis who not only has a ridge, but also has that trigonocephalic head shape with severe narrowing of the forehead. Here's a patient with coronal craniosynostosis. You can see that because of that restricted growth perpendicular to the suture, you end up with retrusion of the forehead on the ipsilateral side, compensation on the contralateral side where it protrudes forward, and you also develop this facial scoliosis where the orbit is pulled up and you get this asymmetry. Let me head back there. You get this asymmetry of the orbits in addition to the frontal bone itself. Keyboard is very sensitive tonight. Here is an example of lambdoid craniosynostosis, which is often the one that creates a lot of anxiety because it mimics a very common but benign condition called plagiocephaly, which occurs when you just have positional flattening of one side of the head. With lambdoid craniosynostosis, on the other hand, you actually have closure of the suture, restricted perpendicular growth, and we have a few mechanisms and ways of differentiating this from benign positional plagiocephaly. Mainly with positional plagiocephaly, everything gets pushed forward on the side that's flat. So you end up with this parallelogram shape on the top-down view, as opposed to with lambdoid craniosynostosis. Due to all the various skull base changes, you actually get a trapezoid turned on its side. From a posterior view looking from the back, you can see that with plagiocephaly, the ears are pretty symmetric, whereas with lambdoid synostosis, there's a tilt of the skull base and this windswept appearance. And so I'm moving through these pretty quickly because I assume that you've heard most or all of these last week. But I do think that before we can really talk clearly about management, getting an accurate diagnosis becomes really, really critical. Part of that diagnosis can be imaging in the right circumstance. We do try to avoid ionizing radiation when we can. And so ultrasound has been gaining popularity as a tool to very easily visualize those sutures. On the left is an example of premature closure where a patient had craniosynostosis. On the right, you can see that lucency and hypoechoic area where there is an open patent suture. All right, so with that very, very brief introduction, let's talk about actual management. So the first thing that really becomes critical in terms of talking to families is what is our goal, right? What are the goals of surgery? And there are a few goals that people will allude to and speak about when they're talking about craniosynostosis. The really number one goal that we emphasize certainly when I talk to families is the aesthetic outcome that we're looking for. So we're trying to help reconstruct the skull, and there are a variety of ways to do that to help attain a normal shape. And that's not to minimize this goal at all. It's a very important goal. We know that children who have craniosynostosis that goes uncorrected can have very severe skull deformities. And there are certainly a lot of psychosocial considerations that go along with that. And so the aesthetic outcome is a very important one that we try to keep very close track of. There are other potential goals, and you'll hear people talk about intracranial hypertension, the potential for developmental delays and neurocognitive issues in patients with craniosynostosis. There's a lot of controversy that surrounds really both of these points. We do know that a certain percentage of patients with craniosynostosis develop intracranial hypertension. It's a much higher rate in patients who have syndromic craniosynostosis, whereas in patients with single suture, non-syndromic craniosynostosis tend to have rates of intracranial hypertension in the range of 10 to 15%. Certainly, if they develop intracranial hypertension, it's very important to address that, but it's very difficult to predict ahead of time which are the patients who are going to go on to develop that condition. And so although it's something that we screen for and watch for and continue to follow patients for, it's not necessarily the main reason that I stress to families for putting all of these patients through surgery. Certainly when it comes to neurocognitive outcomes, there's even more complicated data in the literature, and it becomes very difficult to sort through. So here's some of the, just a sampling of the papers that are out there. There's many more that talk about the incidence of intracranial hypertension in single suture craniosynostosis. There's a variety of different rates that are cited in the literature. When it comes to neurodevelopment, you can see, again, just a small sampling of the many papers that are out there here. But the reason why it becomes such a complicated issue in my mind is because it's really a question of the chicken or the egg. And so many people have endorsed this belief that if the brain is trying to grow, which it does during the first 2 years of life, and there's restriction of growth because of a prematurely closed suture, obviously that could potentially lead to intracranial hypertension and therefore issues with brain development and neurocognition. The alternative hypothesis is, well, if there's something that's structurally going on with the brain in the first place, the growing brain is what gives signals to the overlying dura. And we see that here to release growth factors and signals that then signal the bone above it to grow. And so we know that mechanical strain on the dura itself by the growing brain is very important for skull development. There's something that happens along the way that impedes that growth, and the brain does not put that force on the overlying dura, then you can imagine that you may not have that signal for growth across the suture, and you can develop premature closure. So one of the theories of metopic craniosynostosis is, well, if there's something going on with frontal lobe development, that may prevent the bone above it from forming normally. And it doesn't matter what you do to that bone, if you reconstruct the frontal bones and expand that space, you're still not going to be able to correct the underlying issue. So that's one part of the controversy. There's a lot of studies that are ongoing that are trying to follow these patients very closely over the course of many years to get a better sense of where things stand. Is there really a role for surgery in improving neurodevelopment and minimizing the risk of intracranial hypertension? The most important thing that I think you should all know at this stage of your training, and you'll learn more about this as you move along, but there's really two primary options, two primary categories that we think about when we think about all of the different surgeries that are available for craniosynostosis. Minimally invasive, often that's described as endoscopic assisted, and then the other category is open and open reconstruction. So the surgical philosophy of a minimally invasive surgery is that we're going to remove the strip of bone along the prematurely fused suture and then allow the brain growth that follows to help reconstruct and redirect the growth of the skull. This was one of the earliest surgeries that was done for craniosynostosis, a simple strip craniectomy, and unfortunately it wasn't very effective. It's developed this sort of resurgence in recent years, and it's become incredibly popular for a variety of reasons. And some of it is technological. We now have this endoscopic technology that allows us to work through small incisions, so it makes things a lot safer for the patient. And the second is this understanding that, if we just remove that strip of bone and leave things to natural history, we'll get suboptimal results. But if we guide the growth of the skull after that, we can actually direct which directions and which vectors it's going to move in using a cranial orthosis or helmet. So we can remove that strip of bone, release the plates of bone that have fused, and then using specifically designed helmets, we can say, all right, if it's a sagittal case, we're going to put slight pressure here and here. We're going to leave space here and here. And as the brain continues to grow and tells the skull to continue to grow, it will preferentially grow in this direction and overcome that previously long and narrow shape that we were seeing. On the other hand, with open reconstruction, all of the correction is happening at the time of surgery. So with a minimally invasive surgery, you don't really look that different at the end of the procedure. It takes months for that skull growth to take hold and to reshape the skull. Whereas with an open reconstruction, you have your maximal correction at the time of surgery. And oftentimes we even overcorrect a little bit, knowing that there can be some retrusion over time. In terms of incisions, with minimally invasive surgery, it's usually one incision. With sagittal craniosynostosis, many people use two small incisions. These are about 2 to 3 centimeters in length. They're behind the hairline. They heal very well. With an open reconstruction, we use a bicoronal incision, often a wavy sort of incision, which also usually heals very well, but it is a much bigger incision. And because of the amount of scalp dissection that takes place, there's usually a significantly higher amount of blood loss that takes place with open reconstructions. As a result, the transfusion rate is fairly high with open reconstructions, whereas it is really incredibly low with minimally invasive surgery. And in our own experience, the rate is lower than what I say here at 10%. With a minimally invasive surgery, it's usually a 1 to 2 day stay in the hospital. It's usually one night, whereas with open reconstruction, it can be anywhere from 3 to 5 days. So you can see that there are definitely these short-term differences, and for that reason, a lot of families prefer minimally invasive surgery. A lot of surgeons have, taken on these minimally invasive procedures into their armamentarium. That being said, there certainly is still a role for open reconstruction, and we'll talk about that. One of the key things that really plays a role in determining which patients are candidates for minimally invasive surgery versus open reconstruction is the age at which they present. So because with minimally invasive surgery, we're really relying on the growth of the brain to direct future skull growth, we need that surgery to take place at a point where the head circumference is, or the patient really is still on the steeper part of their growth chart. So we know that the brain and the skull grow quickly in the first 6 months of life, and then gradually that starts to plateau. And so most studies will cite 6 months of age as the cutoff for minimally invasive surgery. We do know that ideally it should be before 4 months of age if possible. On the other hand, we don't want the patient to be too young because we want them to be able to tolerate surgery and the small amount of blood loss that goes with it. And so everybody has a slightly different threshold. For me, it's about 5 kilograms of weight. I usually try to aim for about 2 to 2.5 months of age. There are some slight differences there across institutions, but somewhere in the 2 to 4 month age range is really ideal, going all the way out to 6 months of age. Once you get past 6 months of age, it's just that the skull is growing a little bit too slowly for the cranial orthosis to really direct the future growth and get the optimal results that you're looking for. And so when patients present beyond that time, that's when we really start to think about open reconstruction options for them. So here's the variety of surgical options that are out there for surgical craniosynostosis. In panel A, you can see the 2 small incisions that we're talking about for a minimally invasive endoscopic assisted surgery. So we can use that endoscope to actually look underneath the scalp and go from one incision to the other. And it's important to point out that we actually go past both of these incisions too. And so we really need the entire sagittal suture to be removed in order to adequately separate those 2 parietal bones. That means going all the way to the anterior fontanelle and going all the way to the posterior fontanelle to where it meets with the lambdoid sutures. And so we draw these 2 incisions a couple of centimeters away from each so that we can work between the 2 as well as in front of and behind them. In panel B, you're seeing a slight variation on that theme. So instead of relying on a cranial orthosis or a helmet after surgery to guide growth, there are some groups that are using springs to help keep pushing the bones apart along that vector, and most importantly, prevent the bone from refusing and fusing back across the midline too soon before we have achieved the head shape that we're going for. The main downside to this type of procedure is that it does require a second small procedure to remove those springs once you are done with your treatment. With some of the other panels here, for example, in panel D, you're seeing a similar concept. These are with percutaneous distractors. And so these are devices that come out through the skin that you can turn gradually day by day and gradually move the bones across and away from each other. And with some of these other procedures, you're seeing the open types of procedures. For example, in panel C, there's a larger amount of bone removal and with barrel staves. Here are some examples of patients who are being positioned for endoscopic assisted procedures. On the left, you have what's really one of the standard workhorses, which is the Sphinx position. That gives us access to the entire vertex, front and back. There are definitely some disadvantages to positioning like this, primarily when it comes to the airway. You can see why anesthesia might be nervous in a case like this, because they don't really have ready access to the airway. And if the patient slips a little bit, you can see how that might interfere. And so we really take a lot of precautions when we're positioning patients for this type of surgery. One of my partners, John Martin, had described a variation on that theme a few years ago, where he had actually started positioning these patients in the lateral position, still supine on their back, but there's enough neck mobility in most of these infants that they could really turn their neck in almost 90-degree position to get access to the front and back of the head and really minimize those airway issues that I'm alluding to. Some great papers that came out of the Hopkins group, really nice illustrations here that show how these patients are positioned. Again, this is illustrating the Sphinx position using a specialized head holder, and then using the endoscope through these small incisions to look underneath the scalp. And in these figures on the right, in panels A and B, you can kind of get a sense of what it looks like when you're actually looking up at the screen and seeing that view through the endoscope. So you can get a great view of the underlying dura, the bone, the overlying soft tissues, and there's a variety of instruments that we use in order to remove that strip of bone. Most people describe a 1 to 2 centimeter strip of bone along the sagittal suture that should be removed. And then here in figure 3 is the final result. This is a nice view of the dura. You have to check to make sure there's no CSF leaks, which is very important. And you can see the edges of the bone to make sure that there's no ongoing bleeding. Here's a patient that we treated. You can see her pre-op top-down photos on the left, low cephalic index, very long and narrow head with prominent frontal bossing, underwent a minimally invasive endoscopic-assisted sagittal suturectomy, and this is her 8 months later. You can see that with helmet therapy guiding the growth, she was able to achieve really nice biparietal widening. You really can't even see the incisions. They're hidden under this hair somewhere, front and back. And she achieved a really optimal outcome from a head shape standpoint and is doing very well. There are other options for dealing with sagittal synostosis, depending on the age of the patient again. In slightly older patients, we'll do something called a pie procedure, which was described by John Jane. This typically involves a bicoronal incision and removing bone on either side of the sagittal suture in a pie shape. So this is really the opposite of what we do with an endoscopic-assisted surgery, where we remove this fused suture. In this case, that's the one thing that is left behind, and we're removing bone on either side of it. And essentially what this does, by removing this pie-shaped bone, we're removing bone along the coronal sutures, and sometimes we'll extend it along the lambdoid sutures too. And it creates a lot of flexibility in the bone itself. And so we can drill pilot holes in this part of the bone on either side of the midline, as well as up here, and we can use various types of sutures to bridge that gap and really pull that space closed. And so in one setting, by the end of that surgery, we've reduced the diameter in terms of width, and we've shortened the skull in terms of length. And so you can immediately achieve that head shape that you're looking for. Here's an example of what that bony removal looks like. There's all sorts of variations and modifications of the pie procedure. So this is one of those where some bone was removed along the lambdoid sutures as well. And here's a great example of the time frame, and really the improvement we saw was right away. But this is what the patient looked like pre-op, and here you can see a nice result 2 months later. You get immediate shortening of that AP diameter. When it comes to metopic and coronal craniosynostosis, there are some similar themes. And so with both of those, we have those minimally invasive endoscopic assisted options. Using small incisions, we can remove a strip of bone along that fused suture. We also have an open reconstructive option called a frontoorbital advancement, which allows us to remove the frontal bone and the orbital bandeau and reshape it and put it back. And so I'll show examples of both of those. Here's an example of a patient with metopic craniosynostosis. You can see that narrow forehead. This is a great example from David Jimenez's website. David Jimenez is a neurosurgeon who really pioneered the endoscopic technique back in the 90s, I believe. And you can see he's marked out the metopic suture and the limit of bone removal. And really you can do all of that work through this small incision. Here's a video that we put together a couple of years back showing one of our patients with a metopic craniosynostosis, of course, with patient permission, family permission. And so you can see a slight modification of that incision with a little curvilinear shape to stay behind the hairline. Here we're making that small incision, underscoring the galea in either direction to make sure we get all the way back to the anterior fontanelle and all the way to the frontonasal suture, which is the inferior limit. Here you can see we're exposing the anterior margin of the anterior fontanelle. We're going to expose those bony margins in order to dissect the epidural space, which is what's happening there. Here, there's already been a small craniectomy that can be extended in order to get that initial window. In this case, I actually used a lighted retractor to maintain visualization. So although we often use endoscopes for these cases, that's not always necessary. There are some variations. You can see the fused metopic suture in the middle, this malleable protecting the dura, and then the lighted retractor up top protecting the soft tissues. And then again, a variety of tools that you can use to remove the fused bone. In this case, I was using a diamond drill tip, which heats up the bone as it's being removed in order to minimize blood loss from the bone edges. And here I'm just showing a view of what you can see while I'm working And then at the very end, you should be able to see, I'm going to pause the screen in a second. So where that suction tip is the nasal cartilage that has been unroofed, and that's intentional. So right over here is where that nasofrontal suture was. And I wanted to make sure that the metopic suture had been released in its entirety all the way down to that nasofrontal suture. And so by the time I'm done, I can see that, that top part of the nasal cartilage. And then the final step is to confirm that you're released by actually moving the edges of the skull and visualizing that there's good mobility there. So that's what I'm doing here. This is what she looked like 6 months post-op. So you can see nice widening of that frontal bone there. And she's done very well. Oh, gosh. Sorry, I'm working with a new laptop here, and the mouse is extremely sensitive. I'm just going to rewind a little bit there. All right, so that was our metopic case. With a coronal craniosynostosis, again, we won't go through all of the details because it's really the same concept. You have a small incision. When I do these, I actually prefer to go parallel to the suture. Just in case this patient needs an open procedure down the road, I find that a horizontally oriented incision is a little easier to work into a bicoronal incision. But
Dr. Hirsch?
Yes.
Sorry, I think you stopped screen sharing.
All right, let me try to bring that back.
Sure.
Sorry about that.
Perfect. Thank you.
You can see that?
Yep, we can see that.
Okay, beautiful. And so for those reasons, in this slide, it's showing a perpendicularly oriented incision, and I was parallel incision. But the underlying concept is the same. Remove that strip of bone that's fused, and then use a cranial orthosis to guide therapy after that. Are you still seeing the slides, the open reconstruction here?
Yes, we are.
Okay, perfect. So this is actually a website that you can go to that will simulate a frontal orbital advancement. It's free, and it's a really nice way of practicing and rehearsing the different steps. And so, frontal orbital advancements, these open reconstructions, I find most centers will combine these procedures with plastic surgery and neurosurgery. We use a bicoronal incision. Again, a lot of us like this wavy incision because when the hair grows over it grows in those waves, and so it covers it a little bit in a more aesthetic way. We're usually performing these surgeries certainly older than those minimally invasive ones that we were just looking at. So at least 6 months of age, usually 9 to 12 months of age. And at least frontal orbital advancements are usually being done for metopic and coronal craniosynostosis. There are other types of open reconstructions and calvarial vault reconstructions that we perform for sagittal craniosynostosis, but we're not as worried about the forehead in those cases. This essentially allows us to reshape the forehead and the orbital rim, and it also expands the intracranial volume. And in the simulator that I was showing, they show you all of the different cuts in order to remove the frontal bone. And then working across the orbital bandeau, there's a series of cuts that we have to make across the sphenoid, across the lateral orbital rim, medial orbital rim, and across the nasal bone here. In terms of, step by step, we won't go through all the details today. I think this is a great topic for a cadaver lab and a simulation session to really look at all of these steps in detail. And understanding the 3D anatomy is really critical for understanding where you're going to come across safely. Having really good dural dissection and protecting both the epidural space as well as the orbital contents is really important when we're making these cuts. And again, here you can see another nice three-dimensional view of that. Here's an example of somebody who had metopic craniosynostosis. And so you can see their trigonocephalic head shape here. The orbital bandeau was removed separately from the frontal bone. Using a little strip of bone in the middle, they were able to recontour that orbital bandeau, give it a much more normal appearance here without that trigonocephaly, and then it was replaced. And here on the AO website, there are also some really nice figures that are showing the amount of advancements that we typically obtain, as well as the recontoured orbital bone here. In most cases, you'll see that we use resorbable plates and screws. And so in these age groups, we really try to avoid titanium, because you'll find that as the skull continues to grow, the titanium can actually erode through the bone and into the dura itself. And so really what most people are using these days are these resorbable plates and screws in addition to sutures. So there's so much more that we could talk about. Really what I focused on tonight is non-syndromic craniosynostosis. There's a whole separate lecture that we could talk about in terms of syndromic craniosynostosis, because there's a lot of different techniques that we have at our disposal. Some of those are the same ones that you've heard about tonight. There is a growing movement to offer minimally invasive procedures as long as it's at a young enough age for patients with bicoronal craniosynostosis and syndromic craniosynostosis. But there's a whole variety of pathways and algorithms that we follow depending on whether the patient has intracranial hypertension, papilledema. What are the main considerations? There's posterior vault distractions, which we didn't really talk about tonight. There's the frontal orbital advancement. Some groups prefer to start with one versus the other. And so that's a whole nother topic that we can save for another night. But I think take-home points for tonight should be that craniosynostosis can usually be diagnosed based on the physical exam alone. There are some cases where imaging can be helpful, but doesn't have to be done routinely. Early diagnosis prior to 4 months of age is ideal, because that's what offers us the greatest flexibility in terms of our management options. If we can make the diagnosis early, we can at least offer a minimally invasive procedure. Whereas if we don't make the diagnosis until after 4 to 6 months of age, we still have great options in terms of the open approaches, but we just don't have that flexibility anymore. In single suture craniosynostosis, the goals of surgery are primarily aesthetic. We certainly have to keep intracranial hypertension in mind and screen for that, but the impact on neurodevelopment remains very controversial and a topic of ongoing study. Whereas with syndromic craniosynostosis, there are much higher rates of intracranial hypertension. It requires a multidisciplinary approach. The goals of surgery are usually different. But in all of these cases, options include endoscopic assisted surgery, very importantly, followed by helmet therapy. And patient compliance is very important when it comes to that. But that's what allows us to harness that ongoing growth of the brain versus these open reconstructive approaches, which you've seen here tonight. So I know it was a little quick, but I think those are the highlights, and I'll be happy to save a few minutes here at the end for questions.
All right. Thank you so much, Dr. Hirsch. Hopefully I'm not lagging out here. But and if anybody has a question in the chat, please feel free to chat and we will read them and answer those questions. So something I was wondering about, you mentioned the plate versus spring debate, and the springs could be helpful, but also you have to remove them later. What do you usually use? And if you vary, is there a certain situation in which you use the springs versus the plate, and why?
It's a great question. I find that there are certain centers and certain surgeons that really like using the springs for the reasons that I mentioned. They prevent early closure of that bone across the midline again. And so there are some centers that have become really big proponents of using spring-assisted surgery. I have not really adopted that in my own practice. I've found to have had good success with the endoscopic assisted procedures followed by helmet therapy. So that's always been my preference. But I certainly see the pros and cons of both.
Makes sense. And also I was wondering, because a big point of your talk was also the aesthetic considerations for children and undergoing this procedure. Do you also work with plastic surgeons to accomplish this? And how do you counsel families on something like that?
So we work really closely with our plastic surgeons. We have two great plastic surgeons, Chris Hughes and Charlie Castiglione, and we have a great craniofacial team. What you'll find at most centers that have a focus on craniofacial surgery is that there will be a really large multidisciplinary team that is run by a craniofacial coordinator. And so there's a team coordinator who helps bring together plastic surgery, neurosurgery, ophthalmology, developmental pediatrics, ENT, speech therapy, and the list goes on and on. And so we meet routinely in clinic where all of these different groups come together and we all evaluate patients on the same day so that we can save them various trips to the hospital. And it really becomes an important team effort. What I find in terms of actually performing the surgery is that when it's in these younger age groups and we're performing a minimally invasive strip craniectomy followed by helmet therapy, that's something that we will usually perform on our own as neurosurgeons. Whereas with the older patient group who's undergoing an open reconstruction, we work hand in hand with our plastic surgeons in the OR. And we're usually involved in the approach and performing the epidural dissection, protecting the underlying brain, and doing the craniotomy and removing that bone. The plastic surgeons will then come in and help reshape it, and then we all put it back together. And so it's a little bit of a dance in the OR.
Absolutely. It seems like you definitely need comprehensive care for these types of pediatric patients. And even though there are a lot of cooks in the kitchen, it seems like it works out quite well that way, doing it with that interdisciplinary approach. Even just discussing patient's care gives it more attention, which I think is important.
Absolutely.
Something else I was wondering was, there are also specific genetic conditions that predispose to some of these craniosynostoses. I'm assuming by the point that a patient comes to you looking for surgical intervention, they know of that genetic predisposition or maybe the defect that occurs there. And so I was wondering, do you ever have to counsel patients, families, et cetera, on that type of thing?
It's a great question, and it's definitely one of the top questions on patients' families' mind, right? If they have other kids, do they have to screen them? What if they want to have future kids? What we find is that with non-syndromic craniosynostoses, there often are genetic mutations that are identified, oftentimes in the FGFR family, the fibroblast growth factor receptor family. And a lot of those mutations do end up being sporadic. And so they're not mutations that were inherited from the parents. With syndromic craniosynostosis, again, there's over 150 different individual syndromes that have been identified now. The two most common ones that you'll hear about are Cruzon and Apert syndrome. And there's usually other phenotypic issues that are ongoing, both in the craniofacial skeleton as well as potentially other parts of the skeleton. With Apert syndrome, most of those patients have syndactyly, so you'll see issues with the hands and feet as well. So with syndromic craniosynostosis, we find that the diagnosis is often made really early, and those patients undergo genetic testing early on. With non-syndromic craniosynostosis, a lot of those patients came in because either the parent or the pediatrician noticed that something just looked off about the head shape without actually having the diagnosis when they come into the office. And we're the ones who provide them with that diagnosis based on what we assess in terms of the head shape. A lot of them will then go on to get genetic testing. It's not universal, for a single suture sagittal craniosynostosis patient. I don't know that it's critical that they go on to get genetic testing. Certainly anybody with multi-suture craniosynostosis or known syndromic craniosynostosis, genetic counseling can be very important. And just like everything else, we have a dedicated genetic counselor who will work with these patients.
Absolutely. And yeah, it definitely is interesting that you would actually have to make the diagnosis in your office, which is something I didn't actually think going into this talk that would be the case. And actually, we have a question from Dr. Rad. I'm going to see if I can actually show it on the screen here. And which surgery is your favorite or most interesting of the 150 or so that you could do?
I'm assuming we're talking about craniofacial surgeries in particular.
I believe so.
All right, not neurosurgery in general. That's a topic for another night. But yes. Of all the surgeries that I do for craniofacial diagnoses, I think a minimally invasive sagittal synosectomy is just my favorite surgery for all the reasons you would think. It's every surgery has risks, but it's a relatively straightforward procedure. It's quick. Patients go home the next day and they have amazing outcomes. And so it's hard to beat that.
Definitely. And I guess one last question I have for you is, in terms of cost to families for a procedure like this, are you familiar with maybe what the cost would be or whether a lot of insurances cover something like this?
That is a great question. The answer is insurance does cover it. The helmet therapy after the surgery is always an interesting question because people typically think about helmets in the context of plagiocephaly, where all the sutures are open, but because of positioning, one side of the head has become flat. And so you'll see a lot of kids who are going around in dock bands or helmets of various kinds to help reshape that flattening. And those helmets, depending on the state you live in and what insurance you have, may or may not be covered by insurance. At Connecticut Children's, we actually worked very closely with Connecticut Medicaid, called Connecticut Husky, to get these helmets approved when they're appropriate. So we used the Congress of Neurological Surgeons guidelines that were put out a few years ago to show the insurance officials that there are very reasonable indications and scientific indications for when a helmet would be appropriate. Whereas before there were a lot of denials that we were seeing, that has changed over the years. When it comes to craniosynostosis, I really haven't had that same issue. I have not yet seen a cranial orthosis denied after a surgery, because I think it's very well recognized that it's an important part of the treatment algorithm, that it's medically necessary in order to achieve the goals of the surgery. And so I haven't had any issues there. Most of my patients are going through 2 helmets because their skulls are continuing to grow after the surgery. There are adjustments that we can make while that's happening, but at some point they usually outgrow the first helmet and need to have a second helmet made in order to complete their treatment. And again, I haven't had any issues, knock on wood, with insurance companies denying either the first or the second helmet. There have been a lot of, maybe not a lot, but there have definitely been a decent number of studies that are in the literature now. Matt Smith, who's now down at All Children's in Florida, he put out some great papers about the cost effectiveness of minimally invasive endoscopic assisted surgery compared to open surgery. The argument being that, okay, it's a smaller procedure, it's less time in the hospital, you're not using all those resorbable plates and screws, so that would lead you to think that it's more cost effective. But on the other hand, you need to wear these helmets postoperatively, and those involve multiple trips to the orthotist, usually every 2 to 3 weeks, and maybe that will add up and make it more expensive than a one-time open procedure. And he actually found in his papers that the minimally invasive approach is more cost effective than the open procedure. So not only is it a shorter recovery for patients with equal, if not better, aesthetic outcomes, it's actually also more cost effective.
Wow, just adding to the fact that that clearly is a far superior approach if you're able to do it and you have the resources. So that is amazing. And it's amazing that you also push the boundaries forward on making these plates a little bit more affordable under Medicare. There.
Yeah, I'll just give you one disclaimer, which is that I'm a big believer in this minimally invasive approach. There are definitely surgeons who are out there, some plastic surgeons, some neurosurgeons, who really are still they haven't bought the story yet, and they know that open procedures work well, and that's what they've known all their lives and are comfortable with. And there definitely are people out there who do not think that minimally invasive surgery is the be all and end all of craniofacial surgery. And so just know that when you're talking to people, is that I think it has gained traction over the years. And certainly at our meetings, at our national meetings, we always have these counterpoint debates. And it's always comical because they put up 2 people, one person to argue for, one person to argue against, but they're both leaders in minimally invasive surgery who have both published plenty of papers about the advantages of minimally invasive surgery. So I think that kind of shows us where the pendulum has been swinging.
That is really funny. And it's great that it adds to the academic discourse there in terms of these different approaches. But they also probably should select some other individuals who are maybe on the other end of the pendulum there.
Yeah, well, just harder to find these days.
Oh yeah, I'm sure. So just I'm recognizing the time there. I want to be cognizant of it. Just have one follow-up question from Dr. Rad, and that is, it was a follow-up.
Microdisc or craniofacial. Yeah, yeah. I think you always have these debates when new technology comes out, when more minimally invasive approaches come out. The question becomes, obviously, minimally invasive surgery has appeal, right? It has appeal to families. It has appeal to us as surgeons. It has appeal to the system from a, getting out of the hospital faster standpoint. The real question that you always have to ask when you're faced with these new approaches is, do they still achieve the goals of the surgery in an equal, if not better way? And so I think that question has been asked appropriately of minimally invasive craniofacial surgery over the years. And there's a really nice body of evidence now that shows that it is effective if performed at the right age range and if families are compliant with the helmet therapy postoperatively.
Definitely.
Great question.
Thank you so much, Dr. Hirsch. We really appreciate your presentation tonight. I also wanted to give a shout out to Nikki, who's another education director who helped to put together this event. So we're very grateful for her work. And thank you everybody for tuning in. We would appreciate it if you liked, comment, subscribe on all these different platforms you're on, and tune in next week, Tuesday, and also for our shows tomorrow and Thursday. Thank you so much, everyone. Have a good night.
Okay, hi everybody. Welcome to the third in our Craniosynostosis series, specifically our journal club session. We have a few different announcements for you that we'll try to get up on the screen shortly. There we go. So first, tune into the Neurosurgery Journey live every Thursday at 7 Eastern. We also wanted to share that our Women in Neurosurgery event is coming up on February 25th. Sorry, things are a little bit out of order here. In addition to that, the next thing on our list is we're going to be talking about the Clinical Students Guide, I think on Thursday for our next live, and we are also doing a service fundraiser currently for brain and spine injury. So there's more information there on how you can donate. Our goal is to get to $15,000, and we definitely need your help to do that. Okay, so I think that's about it. This one.
That's all the announcements?
I think so.
All right, so get everyone introduced and warmed up before we dive into the meat and potatoes then?
Yep. So we have Dr. Meltzer joining us this evening. How are you doing tonight?
Doing great. Thanks for the invitation.
Yeah, of course. Just give me 1 second here.
I think there's another student presenter joining. I'm going to be pinch hitting one of the articles. I guess presenting journal club is not people's preferred Valentine's Day activity, but I guess there's 3 articles we're going through tonight. So I'll present one, Nikki's going to present one, and then there's another student maybe having some link access issues. But we'll get through everything and have a good time doing it.
All right. So just to introduce Dr. Meltzer before we get started, Dr. Meltzer is the Chief of West Virginia University Medicine Children's Pediatric Neurosurgery. He received his MD from Northwestern University here in Chicago, where I am currently. And completed his residency at the University of California, San Diego Medical Center. Dr. Meltzer was recruited to act as a thought leader for developing pediatric neurosurgery at West Virginia University. His specialties lie in the treatment of craniofacial disorders, including the development of novel, minimally invasive endoscopic procedures, as well as innovative cranial vault expansion techniques. Dr. Meltzer was always interested in medicine, even as a child, primarily because of the opportunity to help people and to make a difference in people's lives and society. During his medical training, he was drawn to neurosurgery, and then came the opportunity to work in pediatric neurosurgery. He grew up in Chicago and practiced for over 20 years in San Diego before being lured to West Virginia University Medicine by his colleague and mentor, Dr. Mark Lee. So with that, I think I will go ahead with the first presentation here, and then we'll have a few minutes for discussion after that. And then we'll move on to our next presentation. And we would, Dr. Meltzer, before we get started, if there's anything that any comments that you wanted to make or further introduction, we would love to hear it. But otherwise, we can get started and kind of discuss as we go. It's up to you.
I think we should jump right in, but thank you for your kind words.
All right, give me 1 second to get this on screen.
And obviously, anybody in the audience, if you have questions, comments, anything you want to bring up, just go ahead and send it right in the chat. There's all of us here kind of watching, monitoring. We'll throw your questions up on the screen so everyone else out there can see them. And, we'll have a good time doing it. So with that, I'll be here monitoring chat until it's my turn.
right, does that look okay on screen?
Yeah, it looks good on my end.
Okay. All right. So just to get started, we're going to start with I should say the first of these two articles were chosen from the Congress of Neurological Surgeons list of landmark papers in neurosurgery. So they are a little bit older, but they are nevertheless very important papers in defining craniosynostosis management. The first one is Sagittal Craniosynostosis Outcome Assessment for 2 Methods and Timing of Intervention. And it was published in 1999. So bear with me. I believe this was a photocopy of the article because I had trouble finding a digital copy. First, a little bit about craniosynostosis. Craniosynostosis is a birth defect where the bones in a baby's skull fuse too early. So the soft fontanelles in a baby's head or the lack of closed sutures allows the baby's head and skull or the skull to grow along with the brain. And when craniosynostosis occurs, you can have various sutures. The sutures that fuse too early define the type of craniosynostosis that prevent the brain from growing normally. And if it goes untreated, that can lead to buildup of pressure in the brain that can lead to various problems, including blindness, seizures, or brain damage. And in addition to that, what probably most parents end up coming in and seeking treatment for is the fact that there's distortion of the skull as this problem goes on that causes essentially abnormal skull shape, which is usually what parents end up coming in for. So the research question for this paper was which type of surgical procedure has the best outcome for craniosynostosis, specifically sagittal craniosynostosis, extended strip craniectomy or subtotal calvarectomy. This was a retrospective quantitative analysis, and it included children that had non-syndromic sagittal synostosis, had an operation before the age of 13 months, and had 3D CT scans completed before surgical treatment and approximately 1 year after surgical treatment. Some of them also had perioperative CTs. And as I said, this was specifically for sagittal synostosis. So this first figure kind of demonstrates the 2 different types of procedures that were used. The one on the left is the extended strip craniectomy. So they essentially remove an H-shaped strip of bone from the skull without really affecting any of the other bones in the skull. So no osteotomies are performed on the frontal bone, the temporal bone, or the occipital bone. By contrast, the subtotal calvarectomy and cranial vault remodeling involves multiple radial osteotomies on the frontal bones, as well as on the occipital bone. And so they essentially remove the bones and then reshape them and do some remodeling of the skull. So it's a bit more extensive than the extended strip craniectomy. So for this study, they had, I believe they initially had about 60-something potential subjects. They got whittled down to 40 based on their inclusion criteria, and they had 28 that underwent the extended strip craniectomy and 12 that underwent the subtotal calvarectomy. There was definitely a skew toward male babies in this study. They didn't specifically comment on that, but the ages for the groups were about the same. And to assess the outcome from the various procedures, they used cranial index, which is the ratio of the maximum width to maximum length. So width divided by length times 100 is how you get the cranial index. This can be measured with skull radiographs, direct measurements of the skull, or CT scan data, which is what they were using in this case. And that's really, at least up until this point, maybe there are now other ways that they assess this, but at the time that was kind of the best way to really assess the outcome of these procedures. So they were looking at both the different types of procedures, the extended strip craniectomy and the subtotal calvarectomy, and also the timing of the procedure, because they looked at babies that had this done prior to 4 months of age and after 4 months of age to see if the timing of the procedure played any role in the outcome. So as you can see here in this table, there was a greater average percent change in the cranial index, following the subtotal calvarectomy as opposed to the extended strip craniectomy, so almost twice as much change. when they looked at the preoperative relative to the postoperative cranial index. They did remark that, and I think it sounded from the paper that this is pretty typical, that there was a bit of a regression in between compared to the sort of immediate postoperative cranial index to a year later, that they kind of saw some regression in the cranial index that then went back to normal over the course of a year. So they have some photos here of the 4 days post-op for the extended strip craniectomy and the subtotal calvarectomy with those 3D CT scans that you can see. So what they looked like immediately afterwards, essentially. And then as they went on, they graphed this to look at the change. It's kind of hard to see with the different tones that they used for extended strip craniectomy versus subtotal calvarectomy, but the solid color is the subtotal, and then the other shade, the other color is the extended strip craniectomy. So you can see that most of those patients fell to the left of the graph, meaning that they didn't have as much of a change in the cranial index over time compared to the subtotal calvarectomy patients. And they also looked at, so on the left graph is extended strip craniectomy, on the right graph is subtotal calvarectomy. And the gray area, which again is hard to see because this is a photocopy, so I apologize for that. The gray area is what is considered normal range for cranial or cephalic index. And they found that a greater number of babies in the study after a year ended up in the gray area or the normal range on cranial index than did those that underwent the extended strip craniectomy. So each of those marks represents a participant in the study, and then the shape of the mark indicates whether that was their measurement pre-op, peri-op, or post-op. So again, this is some of those images. You can see what this looks like after a year of one versus the other, and that there's been a lot more, I apologize for the noise, continuous remodeling of the skull in that subtotal calvarectomy group relative to the extended strip craniectomy group. Then looking at the statistical comparisons of the effect of the surgical procedure on cranial index, the difference actually wasn't ultimately significant, but they did find, as you could see there, that there were better outcomes with the subtotal calvarectomy in terms of the pre-op versus post-op findings. And then this next table looks at the age of operation. So specifically in that extended strip craniectomy group, they compared when the procedure was done at or less than 4 months of age versus over 4 months of age, and found that there wasn't really any differences there, because I think traditional wisdom at the time kind of suggested that the earlier the better, and they didn't, in this study at least, find that to be true. So that's what we're looking at here. I apologize. So the main conclusion of all of this really is that even though the subtotal calvarectomy with the surgical remodeling is a more extensive operation, relatively speaking, if the goal of the surgery is to normalize the cranial index, then that operation is generally more effective than the extended strip craniectomy in doing so. And the age at surgery, at least for the population here that was between 1 and 13 months of age, did not affect the outcome for these particular operations. So I will leave it at that, and we can maybe have some discussion of that before we move on to the next one.
Yeah, I just went ahead and brought in everybody on the panel. We can kind of open it up for discussion. If Dr. Meltzer has comments or anything he wants to start with, now I've got a question or so I can sprinkle in as the conversation progresses.
So, Nikki, what did you think of this paper? Do you have any thoughts about it after you reviewed it and studied it? What do you think?
I mean, I'm not sure if it's more common for male babies to experience this, but I did think it was interesting that the groups were so skewed towards male babies. That was one of the first things I noticed was, is that to be expected in a study like this? or is
I always wonder about that kind of thing, especially in things that are 20, 30 years old.
right?
You wonder about gender bias. I don't know so much in this particular study, but I will share with you one story from a pediatric neurosurgeon in another country that gave a talk about a surgery they were doing called endoscopic third ventriculostomy that has a very high rate of not working in certain populations. But he said, we do it a lot in girls because people don't really care how they turn out anyway. They don't have to do much more than like cook and clean. So we don't really, it doesn't really matter that much. And that was you couldn't get away with that. You really couldn't get away with it then. Now forget it. It's outrageous. But you always wonder, is there something going on, right? When people make these decisions, if someone says, well, that's okay, we're not going to change this head shape, doesn't matter that much anyway, versus someone else. And there are biases, right? There's biases, there's racial biases, gender biases, there's economic biases, right? These are like really important topics. There's a lot of literature about this now. If you look at more modern literature. So I think that always does have to go into your thought when you're looking at something critically. That might be the first thing that could come to your mind. But I would also let you know that it's also known that for whatever reason, and I think this is pretty much bias taken out, this disease seems to be more common in men than women. Okay. So reasons that are unclear. But it does seem, and it's well known, that it does seem to be more common in men than women. But I think it is worthwhile to look at that. And I think anything you look at these days, you've got to look at it through all the different bias lenses because we know they exist. So I think that's a very valid comment to make. Although I think in this case, it's been shown that for whatever reason, this disease happens to be more common and no one really knows why, but more common in men. But I will tell you there is bias in this paper though. Maybe not in that, but there's other areas where there is bias in this paper. So, what do you think of the names that they named these two procedures? Which procedure is actually the bigger, more invasive procedure?
I mean, the subtotal calvarectomy from the images appears to be more invasive.
When you hear the word subtotal, do you think that
doesn't sound less invasive or more invasive? It sounds less invasive.
Yeah.
And what's the other surgery called?
And did they call that surgery? Yeah, the extended makes it sound like it's extended.
There's some messaging going on here that these authors have got some bias where, and I know who some of the authors are, and they're not known for promoting minimal invasive procedures or endoscopic procedures. So I think that, there is some messaging, maybe subconscious or conscious, the way they name these procedures. Yeah. They name the more invasive, aggressive procedures subtotal, and the less invasive, they call extended. So that's already, And then how about what kind of comparisons do they look at? Do they look at things like length of stay, blood loss, risk of transfusion? Was any of that included in there? Yeah. I mean, they probably had that data was available, right? Do they look at that data at all?
You would think, because it's a retrospective study, so you would think that all of that information would have been available, but they focused exclusively on the cranial index, which they even acknowledge that doesn't take into account a lot of other factors that go into a decision to do a procedure like this, like the cosmetic aspect of it, the sort of psychosocial aspects of having a big procedure like this are sort of not taken into account by a cranial index. That's really, it's a measure of length and width of the skull at the end of the day.
Mm-hmm. Although maybe the best we have right now, although I'm reviewing a paper that they talk about some other indices they're working on, but there is a criticism of this, but it's what we have. So I don't think that necessarily is a poor metric, but I think there's more metrics than that. When you compare a procedure to another, it's not just what one outcome measure is. There's a lot of data you can look at. And I think what you'll find if you look at papers critically, you'll see that very rarely do the authors have no kind of internal bias before they start. They typically have an idea of what they think is the best, and they'll tend to highlight that. They'll it's like an argument in a court of law. You're going to highlight the things that are going to be in your favor and not highlight the things that aren't when you're making your argument. So now the best papers tend to be even-handed, but I might suggest there was some data probably left out that might have made things a little more not so straightforward as to which is the quote unquote better procedure. But I think from a historical standpoint, this paper is important because it tells you that if you do like a strip craniectomy or a suturectomy alone, that probably is not enough. That's historically maybe 100 years ago when people were first trying to do any procedure, and you could die on the operating room table from blood loss with these procedures. A minimal procedure was the safest. But just doing that, removing one strip of bone, is probably not enough to get you a reasonable result in modern times. I think in that sense, this paper is very helpful in that it kind of puts to rest that you can't just remove probably a strip of bone. You've got to do more than that. And so they show a procedure where they do a lot more than that, and it seems to be a better outcome. So I think in that sense, that's why this paper, or some people consider this paper to be very important or a landmark paper, because it does kind of put that to rest as things evolve, as knowledge evolves over time. But if you look at that one slide you put up of the outcomes and which group had outcomes in that gray zone, I might argue that neither procedure looks very good to me.
Yeah, I had the same thought.
You should all be in the gray zone. I mean, the point is that, craniofacial surgery, people, back in the day, they would make jokes, weren't very nice jokes. And people would say, well, this is craniofacial surgery. You're taking people who are deformed and you're making them look ugly. I mean, it's not really, in other words, it's not really giving you want to take someone and make them look normal. You want to do a surgery that corrects the problem, that maybe makes it a little bit better. And when you show that graph of all these numbers that are outside, even the best, the so-called better surgery still has a lot of people that are outliers. So it means, to me, we have a lot of work to do. At least 20 years ago or plus, we still had a lot of work to do to get people with outcomes that we would consider acceptable outcomes, which would be in the normal range. That would be your ultimate outcome, not just to look improved, but you would want to be in a normal parameter. So I think that's another take-home message. I look at this paper historically is that we had a lot of work to do still to get to where we need to be, get the outcomes where they need to be. You should all be in the gray zone, ideally.
Yeah, absolutely.
Or in the gray zone, but you should all be in that gray zone.
Yeah, and I wondered too, with the advancements in plastic surgery as well, how that's helped to contribute to better overall shaping the skull, to your point about, reaching normal as opposed to just fixing a deformity. All right.
It was really nice
back,
job, by the way. Really nice job.
Going back to the original topic of discussion about gender bias, the question that had come up in my mind is, in your clinical practice or just kind of anecdotally over the course of your career, have you seen that parents make either different surgical decisions for their baby boys versus baby girls, or maybe if it's not whether to operate or not operate, but to allow their daughter or son to be enrolled in a trial, that you think could be skewed towards a bias of, maybe we're okay with having our son enrolled in a trial if they want to collect data on him, but we're not going to have our little girl enrolled in a trial, or vice versa in terms of aggression of surgical decision making from the parents specifically?
Not that I've seen overtly. I think that would be, in our culture and the society, that would be unacceptable, or it would be outrageous. Now, subconsciously, you never know.
Yeah, right? I mean, more subconsciously, obviously, probably not overtly.
Yeah, but you have to accept, these things, and I think as we're becoming more knowledgeable, that's the way you fight bias, is you accept it. You accept that there is such a thing, And once you accept it, then you can work against it. So that's usually the strategy that we use to combat that. I think, obviously in the entire world, we have a lot of work to do. But it doesn't mean we don't have other biases, though, that we deal with that I think are much more common, unfortunately. But I think in this disease process, we can probably put it to rest, because I think there's been so many studies over and over again showing the incidence seems to be just higher in male than female for whatever reason. I think it goes beyond bias too. That's the disease process, which we know does happen not infrequently. But very good question, and these are things pretty much every disease process needs to be looked at through a lens of bias, as we discover more and more about that.
Awesome.
All right. Do we want to move on to Jose's presentation of the next paper?
Good for me. You ready to go next, Jose?
Ready to begin.
All right. I think there should be a button down at the bottom. Just go ahead and screen share, just like Zoom. And then once that's up, we can get the screen all shuffled around. You able to find it there? In the meantime, we'll just say, Raina, thanks for your comment. That's why we're doing this. Keep the conversations fresh. Keep a good perspective on everything. Thanks for joining Journal Club tonight. We appreciate it. Jose, how we looking? You able to find that screen share for your slides, or?
Where is it?
So it should be right in the middle of your screen. Should be a little computer screen with an arrow, kind of similar to Zoom. Just click on that and it should ask you which window you want to share.
Okay. Okay. See.
We'll probably turn this off for a second while he finds his slides. If not, we can jump to the next article if we can't get his slides pulled up here. Admittedly, the next article is going to be a little. We're gonna be shooting from the hip a little bit on the next article, or my article. I've had about 30 minutes to review it, so we've done no background research. But I've got. What do you want to do, Nikki? You want to just start the next article while you guys troubleshoot Jose's presentation?
Jose's slides, so I can bring those up while you're presenting, and we can share my screen as well.
Sounds good. I'll trust you and Michael get IT taken care of, and I'll take up some bandwidth in the meantime. All right. So obviously, glad to be here. This is not. I was not the original person scheduled to be here. I'm just going to go ahead and pull up. I don't have slides or anything because I was prepared very last minute. So what I'm going to do is just pull up the article verbatim. And my thought was I'm going to kind of just go through it and kind of point out the things that came across in my mind and sort of give, rather than like a typically prepared journal club with slides, more or less just kind of think in real time, what's going through my head as I'm reading this article and evaluating it. So the overall like big picture of the article is this comes out of the Toronto group. And what they did is a systematic review and meta-analysis comparing endoscopic sagittal suturectomy versus typical open surgery for sagittal suture craniectomy. And all they want to know, the big question they're asking is endoscopic, minimally invasive surgical techniques equivalent or superior to traditional open surgical techniques for sagittal synostosis? The way they did that is through a pretty standard systematic review, which is what they're documenting in their first figure. Now, for anyone that has not done a systematic review, this is pretty bread and butter, right? You pick a handful of, I assume you guys can all see my cursor here. I mean, are you guys able to see? Do I need to zoom in a little bit? Let me see. I can probably zoom in a little bit better. Give you guys a little bit better picture. So this is a typical flow chart you would see for any systematic review. It simply just starts by being, the whole point of it is to be extremely transparent about what your research methods are. What are your searching and evaluation methods for the paper that you're presenting? And what they're doing is they're listing the databases that they searched, how many results they found based on the search terms that they used. And then they simply go through their criteria. You know, they remove duplicates that were returned in the same. So then that reduces the, you know, from their initial search of 489 articles, they've reduced it down to 316. And then they screen those to exclude another 288 from these 316 articles. So that gets them down to a roughly like preliminary eligibility of about 28 articles, from which they then institute the inclusion criteria or inclusion and exclusion criteria of the study, which I'll touch on in a second. And once they exclude all their papers, it brings them down to roughly about 10 more papers, which they do like a full text analysis and see if there's any other exclusion criteria that would eliminate a study from inclusion in their final meta-analysis. And ultimately what these authors found in their systematic review was that there's 3 articles that met full inclusion criteria for comparing a cohort of endoscopic versus open surgery treatment of sagittal craniosynostosis. That's the lay of the land here. So everything I already went through was pretty much their search strategy, their inclusion and exclusion criteria. This is sort of the next piece of the puzzle that I think of in my head when I'm thinking how I want to evaluate the methods of a paper, is simply like, how do they pick the subjects, or in this case, the papers, because the papers are their subjects. How did they pick their subjects, and how do they decide that subjects or certain papers were not sufficient to be included? And basically what they want to know, they want to include papers where the diagnosis of sagittal craniosynostosis was made officially by a plastic surgeon or a neurosurgeon, so not like a presumed diagnosis, right? Because there are, obviously I don't have an extensive clinical training in craniosynostosis, so I'm not by any means an expert in this, but my perspective is, to the untrained expert, something can seem misshapen, but then, you know, when evaluated by an expert, is not, the underlying cause is not deemed to be from premature closure of a suture, right? So they want to make sure that they're only including papers that are distinctly studying a population where the diagnosis was made by a trained expert. And then they also wanted papers where at least 50% of the patient population had isolated sagittal craniosynostosis. So there's a lot of papers out there where they're looking at craniosynostosis at large, various subtypes of craniosynostosis, and the population of patients evaluated in that paper is a mixed cohort. What they want to know is that they have at least a concentrated cohort of at least 50% where the patient population has isolated sagittal synostosis, meaning no other type of craniosynostosis is confounding the patient population. The cohorts needed to be divided into open versus endoscopic assisted surgery. So they've defined their primary comparison for their meta-analysis as comparing the minimally invasive technique to the open surgery technique, and they are only including papers that are directly comparing those outcomes in their paper. And then they obviously needed follow-up in these patients because they want to be able to report on what the actual outcome was at 12 months. So if a paper did not include follow-up data at least 12 months or so, I believe they excluded it from the paper. So that is an important inclusion criteria. Then you get into all the reasons why they ruled papers out, right? They didn't have a quantitative comparison between open surgery and endoscopic surgery. So there was nothing. Basically, as you've already discussed from the first paper, the primary quantitative analysis of the main outcome is the cranial vault index. So basically, if the papers weren't looking at that, they had to exclude it. Obviously, they excluded anything that was done in animals or non-human subjects. They excluded syndromic craniosynostosis, which is a big contributor to many of the cases of craniosynostosis. So they're looking at non-syndromic isolated sagittal synostosis, craniosynostosis. And then obviously they want to look at data-driven retrospective or prospective papers. So they took out anything that was an editorial, just an abstract, a review paper, case report, or dissertation to make sure that the type of papers included in their study were exactly aimed at getting at quality papers for their meta-analysis. Now, one of the things I thought was interesting is that they applied this effective public health practice project quality assessment tool to basically take every single paper that came in their result and assign it a rating of strong, moderate, or weak in terms of how that paper accounted for or possibly included selection bias, which we've talked about a lot tonight, accounts for their study design, potential confounders, blinding of the study, their methods for data collection, and the frequency of withdrawals or dropouts from the study, and in order to basically say like, hey, we're using this standardized criteria to assign like a health grade or quality grade to the papers. And so that's the general kind of lay of the land of the methods and what they did. Let's see, what else kind of stuck out to me in terms of interesting methods and what okay, so now you start getting into like, what are they actually looking at? And the primary outcome of what they want to know is the new surgical method clinically comparable to the old surgical method? And the way they really want to know that is by the cranial index, or the cranial vault index score, which I believe the primary outcome was about like 0.71, 0.72. So it was like pretty equivalent between the two outcome methods. But then they start looking at all these perioperative, postoperative outcomes that we were wondering why the first paper didn't really get at them too much. Looking at things like EBL, length of stay, overall operative time, whether or not there were transfusions. Now, the thing that I thought was kind of interesting as I was reading through this paper relatively quickly is they point out that really only 3 papers met inclusion criteria for their meta-analysis. Yet when they're going through all these sort of secondary outcomes, you know, you mentioned here, 6 studies report this. Whereas 8 studies report this. I'm like, how are they getting 6 and 8 studies? So this is actually what I realized. This is a mixed meta-analysis and review. So in terms of their primary outcome, which I think is down here, right, they're only ultimately comparing 3 papers for EBL, 2 papers for length of stay, and 2 papers for operative time, and I believe 2 papers for cranial vault index. So basically what they found is even among the 3 included, there was only one criteria that all 3 could be compared to each other. There was only one length of stay, only 2 papers could be compared to each other, and operative time, only 2 papers could be compared to each other. So it's just a little bit of like understanding of like how, in my mind, how I'm framing the data, because they're making a lot of claims about, you know, EBL being lower in endoscopic surgery. Okay, great. Clinically, to me, that makes perfect sense. So I don't question that too much when I read somebody reporting that in a paper, but they're really reporting that based on, you know, 3 studies that were included in the meta-analysis, not, you know, these like 6, 8, and 10 studies that were, I think there was ultimately 10 studies they included in the review portion of their paper. Length of stay was a little bit lower, 2 versus 4 days in endoscopic surgery. Obviously, that's important from a patient recovery and financial perspective. Operative time was lower in the endoscopic cohort, and transfusion was drastically lower in the endoscopic cohort. So basically, in all the outcome measures that seemingly matter, endoscopic surgery is winning. Now, that only matters if the primary outcome of the effectiveness of the surgery, which is sort of what cranial vault index is a proxy for, which I think really isn't even truly like a real clinical outcome, because if you have, I mean, in my mind, I don't think this is the case, but there's just how I think through these things, right? If you have an equivalent cranial vault index between the two cohorts, let's say you follow one cohort, or you follow these cohorts out till they're 15 years old, and you find out their, neurocognitive development is like drastically worse in one outcome, then maybe I highly doubt that's the case. But that's, I guess, when I think about it that way, that's when I realize that cranial vault index is really just kind of a proxy measurement for a true clinical equivalence. And I don't think we actually have a measure of what that true clinical equivalence really would be. But I would tend to think neurocognitive functional outcomes, neurodevelopment, these are the real true clinical outcomes we would want to know to truly compare clinical efficacy. And in general, just getting into like some of the complications that they had, or the rates of complications, I think they basically couldn't compare. It was the ultimate outcome of the paper. They basically didn't have enough data to truly compare rates of complication. But these, everything's all flipped around. I can't rotate these papers. Maybe I can. Never mind. But in general, the cosmetic outcome, which is your cranial vault index, was basically equivalent. So then they go to the secondary outcomes, and this is kind of summarizing the whole paper. I think I'll just turn that off for a second because it's not doing us much justice sideways. Basically, my takeaway of reading this paper and evaluating it in a shotgun fashion is they had 3 papers that were, 2 of them were a retrospective observational study. One of them was a prospective observational study. Retrospectively, everything seems to point towards minimally invasive surgery as being at least equivalent from a primary outcomes, likely superior from a secondary outcomes perspective. And in that case, why wouldn't you go with the surgery that has better, lower EVL, faster recovery time, faster time to discharge, shorter length of stay? These are all reasons why, if your primary clinical outcomes equivalent, why wouldn't you go with something with these better secondary outcomes? However, I think what the authors do correctly identify is that to truly get to a empirically driven decision, the next step would be a randomized controlled trial, randomizing cohorts to endoscopic surgery versus open surgery. However, with the documented benefits of the secondary outcomes, they do suggest that would likely not be an ethical study to conduct, and we should just kind of assume clinical superiority of minimally invasive surgery. I think some other talking points I may have mentioned, just kind of throwing it all out there. I think there was a slight skew towards male population, but we've kind of discussed that as a group. There was something else in there. Let's scroll back through. I'll take a look, but I mean, that's largely pretty much all I got. So should I bring the team back to comment now? How'd I do, Nikki?
Great.
All
10
right.
out of 10.
I got the seal of approval.
I did just want to address, there was a question in the chat about where the articles are being gathered from. And since there seem to be so many journals and databases and article sources, kind of where do we get these? That I wanted to just let people know that the Congress of Neurological Surgeons does have a publication. Hopefully you can have institutional access to it. Otherwise, it's something you'd unfortunately have to pay for. that has a list of essential papers in neurosurgery that have been extensively assessed and covered by various experts in the field. So that's where some of these articles came from. And otherwise, I kind of tend to just focus a lot on meta-analyses and systematic reviews as a way to look at the overall kind of 30,000-foot view of where the literature is at with things like this. But I'm sure Dr. Meltzer also has advice in that regard.
Well, first I have to give you, that was a great job, especially
Thanks.
just coming on that with a quick 30-minute chance to review it. That's really a really great presentation. So I should start out with, again, in the theme of addressing our biases, that to look at my biases with this paper. It so happens that 2 of the articles that were excluded were my papers. So, so I have to accept that. Although probably they may have included it in some, as you mentioned, they may have included it in some of the data, but not all of it. But you know, they did exclude 2 of my papers in their analysis. But
Do you know the criteria that they excluded it on?
They picked 2 papers of mine that had a lot of atopic synostosis.
Oh, so is it just a heterogeneous population?
One had like 49% sagittal, and they wanted over 50% sagittal.
Got it.
So they excluded one of them for that. But I don't disagree necessarily with the analysis. And this group is a very rigorous, very scientific group, and so they're trying to look at things in the most rigorous way possible to avoid criticisms of the data. So I think that's why they were so strict in their exclusion criteria. But I think that you have to look at this paper in through a lens of a term called equipoise. So have you guys heard of this term equipoise? Do you know what that refers to? So equipoise means things are about equal. That you have different ways of doing things, and it may be that each one has its pluses and minuses, and it may not even be something you can compare, as you kind of alluded to. So I think what people are realizing now is that there may be equipoise between these 2 approaches, and the advantage of this minimal approach is that they use a cranial band to help with the result, and so that's the big advantage over that first paper that gets you the better result. But it has to be in someone who's young.
Yeah.
So there's bias in the age group, because they talk about 6 months, and really it's
actually,
4 months of age. If you're older than 4 months of age, the endoscopic thing isn't going to work, or you might have to wear a cranial band for like a year or more, which becomes a challenge. And the patients in this study, or the ones they look at, need to have a cranial band. What if you're like me, you're practicing in a rural state? They don't have any companies that make cranial bands, or they not really know how to do it after surgery, which is an off-label use of these cranial bands. So how do you even do the procedure then if you don't have access to the cranial band? Well, there's another way to do it where you put a spring in. So that's what we tend to do here, is we use the spring approach to the endoscopic, which is a way to get the same outcome but not having a cranial band. But I think that's your take-home message from this paper is that there's probably equipoise, and it's a bit like apples and oranges. The older kids could do better with that, what we call an open approach, or the cranial vault reconstruction, and the younger kids could do better with the endoscopic, or at least equal to the endoscopic as far as outcome goes, but maybe not have a transfusion, or less cost and length of stay. But your people aren't born with a sign on them saying, I have this disease. You have to figure it out. And so you go see your pediatrician when you're a newborn, like a week later, a month, 2 months, 4 months, 6 months. What if you don't get diagnosed until you're 4 months of age, and you don't make it to the specialist until you're 6 months of age? Well, now you're already too old to have the endoscopic. And that happens a lot. So a lot of people aren't even candidates for an endoscopic. So I think if you're going to do modern craniofacial surgery, you need to be good at both and understand the indications for both. You can do the cranial vault reconstruction on everybody, but you have to wait. You should wait till they're older. So if you only believe in that one operation, you're probably going to tell people, well, come back when you're older and we'll do it. More like 6 months to a year of age, rather than do it at 2 months or 4 months of age. And I think Nikki might have mentioned this one question about, or no, I think you mentioned actually when you spoke about the outcomes. You're like, well, is there some way to measure and also intellectual outcomes? So what if I told you that there actually has been a study that purports that patients who have the minimal invasive endoscopic don't have as good of a neurodevelopmental outcome as people who have a cranial vault reconstruction? What would you say about that? But there is actually
I think it changes everything. That changes everything.
There's that literature is very, very. There's a lot of critiques to that study, but there's at least one paper I'm aware of that claims that a minimal invasive endoscopic approach could have or at least a minimal. I don't know if it was endoscopic, at least minimal invasive may not have as favorable a neurodevelopmental outcome. But I think that's a very controversial statement.
I mean, you have to show that cranial vault index was basically equivalent, but one still had a poor neurocognitive outcome.
And that's the other point that you made that I was going to bring up is that so neurosurgeons tend to be very objective. We like to have objective measurements, and a cranial index gives you a number. But realistically, it's actually a two-dimensional value purporting to give you a three-dimensional measurement. It may not be accurate. So in the pictures that Nikki showed in her paper, she showed like people whose foreheads were bulging out, like frontal bossing. Well, a cranial index wouldn't address that. There were other pictures that she showed of people who had the backs of their heads were tapering out. They call that bulleting, tapering out of the occipital bone. That's not necessarily going to be addressed specifically in the cranial index. But people are looking at different indices to address those types of morphologic changes as well. So I think we will become more robust in how we can compare things and make statements about our procedures. But right now there's a lot of looking at things and kind of saying this looks better, this doesn't, than necessarily having an objective number. And the improvement in cranial index may not really tell you how much better things are looking if it doesn't specifically address things like frontal bossing or occipital bulleting. And so those are critiques of this measurement style. But I think in general, I think the paper is reasonable paper, and it makes the point that probably there is equipoise. If you can get someone younger, they may benefit from the endoscopic if you have access to a cranial band or to the springs, as I mentioned. Then that could be a reasonable procedure for you, and could have outcomes that are equivalent to the more invasive procedure. But if you don't get referred until you're older, then you aren't going to really have an option. So I think that's kind of where this paper, and these people didn't just figure this out for this paper. It's kind of, people talk about that already, but this gives you more evidence.
Yeah.
Because it's, and that's the value of this paper, is that the group is really trying to look at things objectively. They're excluding studies that may not be appropriate, trying to really present an argument that's fairly ironclad. That if you are a candidate for a minimal invasive approach, there are potential advantages to doing the minimal invasive approach, and they lay out those advantages in the discussion section.
All right. Do we want to move on to our last presentation from Jose? I think we've got the slides figured out.
All right. Looking forward to it.
All right.
Are you able to see my slides there?
Ryan, are we able to? I'm not seeing his.
Okay.
Oh, okay.
Are you able to see?
Yep, that looks good to me.
Beautiful. Okay, perfect. Beautiful there. I do apologize for the issues we have with the technology here, and due to the fact that it's Valentine's Day, you know they say love hurts there. So, just my name is Virchow. Currently a medical student at the American University of Integrated Science in Barbados, and normally I have my partner here, Ali, but unfortunately due to the time differences, he's unable to participate here. So, but I appreciate his help there. And today we're presenting the topic on early management of craniosynostosis using endoscopic assisted strip craniotomies and cranio-orthotic molding therapies by Jimenez et al. So, basically the objective of this journal, this study here was basically to assess the safety, effectiveness, and results of early treatment of infants with craniosynostosis using minimum invasive endoscopic strip craniotomies and postoperative helmet molding therapy. Basically, what their approach was to basically find a more better approach to the use of to do these reconstructive fiction of the formation of the cranium there, because in the past they used to have a lot of open surgeries, and the problem with these open surgery was the fact that they had a lot of complications and other problems with it, especially during post operative treatments. So they decided to go ahead and do a more try to attempt to a more minimum invasive approach to it. So how they do it was that they decided to take 103 patients who referred from their craniofacial center and diagnosis of craniosynostosis between May of 1996 to October 2000. And basically they subdivide each groups based upon randomized based upon the formation of the synostosis. This includes sagittal, coronal, metatypic, and lambdoid. And of course, for sagittal, they had 61 patients with 48 boys, 13 girls, with a mean age of 3.2 months. Chromosynthesis had 20 patients with 12 girls and 8 boys, mean age of 3.2 months. Metastructure had 18 patients, 12 boys, 6 girls, mean age of 4.0 months. Lambdoid synthesis, 4 patients, all boys, mean age of 4.1 months. Okay, sorry there. And so therefore, in terms of the results there, when you compare the results of this, what you will find out is that the compare in table 2 compared to table 3, you will see the differences in terms of the outcomes of it. For table 2 was basically the end result of it, and what you find out is that they had, compared to table 3, was that they had less blood transfusions overall, and as well as also post-operative intra and post-operative blood transfusion, as well as blood volume linked hospital stay as well, because they're looking at hospital stay was one of the big areas they're looking at. It was very minimal when you compare it to when you look at table 3. Basically, they did kind of like a literature review on using the conventional approach to it, which basically the open ones. And as you can see here, the blood losses were variance, but very high in numbers, in both for surgical and as well as also for transfusions and longer hospital stay. And to show this next here, you see these pictures of these patients. All on letter A was the before, and then in B was mostly you see was babies with who went post-operative 8 months. And as you can see, that the endoscope approach has shown that have improved the skull formation there, and even once they're all was done, they were placed on these helmets to maintain shape, as for a period about usually about up close to about a couple months or so there, and then afterwards they were follow-ups, and then once they feel there were no shade, they would be removed. There was very little complication in terms of the post-operative there. There was had one dural tear. Most of them, but the most predominant majority common complication was the front, but improved usually within days post-operatively. So, in conclusion, the less invasive technique have shown excellent results in terms of low mobility and no mobility, and associated with low need for blood transfusion, lower hospital costs, and shorter hospital stay. And of course, that the key thing is that, in the author made note of it, is that the key thing is must early diagnosis of this. And as you mentioned in the previous article in your discussions, that if it reaches to a certain point, then that cannot be determined because they passed the threshold of what's considered acceptable. So therefore, that's why early diagnosis should be, so the treatment could be done more effectively. The sooner, the better, and so that way it can improve their chances of using the surgery to improve their craniosynostosis. This concludes the presentation there. Thank you for your time there, and wait for your question.
Ryan, I think you might be muted.
Oh, nobody can hear me. Okay. I was saying, Jose. I was wondering why nobody's talking. Jose, any final concluding thoughts or questions for Dr. Meltzer, or if not, that's okay.
Well, mostly I'm real.
Go on.
What I like about what I was saying, was that I really enjoyed this article here of this study here, because it shows that a more alternate approach to how we approach to craniosynostosis, particularly instead of using the more traditional open surgical approaches where we have a much larger incision and probably have greater complications, as mentioned in this study here. And what I like about it is that this endoscopic approach is that it has, as like any type of minimum invasive approaches, it has less hospital, as well as also even sometimes will stay at all in many cases, as well as also blood loss is minimal compared to the open, where it was so large that oftentimes transfusions were needed. But we find a very alternative treatment modality in order to improve the formation of these craniosynostosis with great outcomes, as mentioned in this article.
That was a really nice job, Jose. What'd you guys think of those pictures that they showed? You guys, what'd you think? You remember some of the pictures he showed in the paper? What do you think, the outcomes?
Yes. It's quite impressive, consider the fact that was only done. You consider the before and after were 8 months post-operative. It was quite impressive. Consider the fact that even though there were some, as I mentioned earlier, there were a couple of complications, but they were very minimal compared to, let's say, if we're doing the traditional open method. I could imagine it could have been a nightmare, to say the least. But I was very impressed at how it was so, how it improved the outcomes. It was so amazing that oftentimes that it showed more the outcomes. What was the targets of this article, as I mentioned, was the outcomes and the without the use of transfusions and hospital stay, which shows it was so minimal that complication was like unheard of, despite maybe a couple, but overall compared to the conventional method, certainly was a tremendous improvement.
How many patients were operated on total?
103. It was 100, about 72 boys and 28 girls, I believe.
And how many pictures were shown?
These were in the article there. Those were the only pictures they have available there in terms of the pre and post operative different outcomes there.
Yeah, how many were there?
There were about 5, I believe, in the pictures I've shown.
4 or 5 out of over 100.
Yeah, those are probably their worst outcomes too, right?
Yeah, so what I'm getting at is I don't know necessarily those. You could say that was a representative sampling of just 4 picked at random. I have a feeling those were probably the 4 or 5 best outcomes out of the 100. I mean, I can't tell you that for sure, but I mean, let's just say this paper. I mean, this paper was like a landmark paper, and it really just like kind of throws down the gauntlet. It's like, you know, this is you know, look what we're doing. This is phenomenal, and that's good. I mean, it generates a lot of discussion, and you gotta take it seriously. You know, someone puts a paper out like that, or these authors. And it's a husband and wife team. And so he's Dr. Jimenez is a neurosurgeon, and his wife at that time, she's a plastic surgeon and craniofacial surgeon. So it's like a team.
Convenient.
So they're just throwing down the gauntlet, like, look what we could do. And so you have to be like, wow, you know, but you have to also look at it critically. I mean, it is just 4 or 5 pictures, and they're probably the best ones by far of any of them. Why put them in? Which is okay. I mean, that's fine. But I think you have to, you know, wonder, you know, did all of them come out like that? And I think we don't know. You know, you have to take the word for it. So as far as like the objective data, cranial index, you know, I think that's adds the objectivity. The matopic with the pointy forehead, the coronal where one eye is like big, like a Popeye kind of look. Now, it's really hard. It's very difficult to get that to where it needs to be with the endoscopic approach. Many authors now, when they show their series in those patients, they tend to be operating on babies that are very young, like less than a couple months old, or they use the springs, which gives you like active force to push the bone apart, versus the helmet, which is more passive and relies on your brain growing to make a change in the head shape. So I think that this paper is a landmark paper. It definitely throws on the gauntlet. Like, if you compare it, it's very close to when that first paper was written, which, you know, was like, this minimal is terrible. Then, you know, don't even go there. And now this person pushes back and goes, oh yeah, look what I got, you know. So you better not, you know, dismiss this so readily, because, and I don't think it's any coincidence that if you look, where were these 2 centers? The first paper is in St. Louis, Missouri, and this paper is in Columbia, Missouri. So these guys are kind of down the road. They're in the same state and probably compete against each other. So yeah. I don't know if there's any coincidence there. I think there's something to that the one group is like, oh, poo-pooing it. Other group is like saying, no, this is like the best way. So you have to look at that too, right? There's something going on there. That I don't think it's just a coincidence. These 2 groups just happen to be down the road from each other and probably are competing against each other. And so this competition, you know, maybe that one paper came out first is like, this endoscopic, don't even go there. Now, well, wait a minute now. Don't be saying that about, because this guy, he did he and his wife did 100. So that's a lot. That's a lot of patients. So they were probably doing this by some overlap. There's probably some overlap in the timing of those papers. Probably while the one group is doing, you know, the other one's doing theirs. So they're probably going out at the same time. You didn't just do 100 patients in a year or 2. I think that's over a few years, and then with some follow-up afterward. So I think, to me, it was really great to pick these out. I'm not sure this intentionally or not, Nikki, but it really shows you 2 sides of the coin here at the same amount of time, same time period, and the same geography. You know, they're probably competing against each other. So it's probably a little bit of competition here. Probably, you know, the one paper so forceful because they probably didn't like what that other group had written. and kind of poo-pooing this way of doing things. So they're thrown down the gauntlet. Well, wait a minute now. Don't you be saying this is not a good procedure. Look what we could do. Now you try to top this. And with like no blood transfusion, going home like the next day, it looks like. I mean, that I believe if that's, that's an objective metric when they say they went home the next day. And no, it is not a way you can't really fudge that very much. So, I think they throw down the gauntlet there, and so they're going to be heard, right? They have a voice and they have a platform, and they're going to be heard, and so they just chuck that out there, and so I think it gives you guys a sense of how this literature thing works, and there's always a backstory going on here, and so these people are have a little agenda probably, which is important to know about, but doesn't mean that the studies are invalid or they're not making a reasonable point, but perhaps making it so forcefully that may have something to do with some of this background backstory to these papers. So I really applaud you for picking those papers out, Nikki, and
thank you.
You did a great job on that one, Jose. So thank you.
Thank you, sir.
You all did a great job with these presentations. I'm very impressed.
I had one other quick question. Have you ever come across any papers that have evaluated it almost from a patient perspective? Because I imagine as a parent, the things that you care about the most are kind of the long-term neurodevelopmental consequences, like we had briefly mentioned, and also the cosmetic outcome. So in terms of kind of like the patient satisfaction with what the outcome was, to your point about them only showing photographs of 4 kids in that one paper, I'm just curious if that's been considered much in the literature as opposed to these more objective clinical metrics.
So I think that we did look at that. I'm trying to pull up the reference right now for you, but did look at that in one group. Sorry, to bear with me.
No problem. You've been very patient with us all evening.
So I can send you a couple references that we have on emotional and psychological impact of craniosynostosis repair, which obviously that would come from family reported metrics. Mm-hmm. I have another paper on comparison of open versus minimally invasive from the parent perspective specifically. Okay. So and that's just my own experience or my group's experience. I'm sure there's others as well. So I think that's really important to look at it from that standpoint. And that's typically why we see people who would like to have a minimal invasive approach, mm-hmm. because they look at it as being less of an issue to deal with when you don't have your child needing a transfusion or having their head swollen and their eyes swollen shut and being in the intensive care unit versus being in a regular room. So that's another reason why I discussed with some of my colleagues the advantages of doing a minimal invasive approach is that many people seek it out. And when we first started doing these procedures, we would have people fly from all over the country when they heard that we were willing to do a minimal invasive approach, because it seemed to the families that was the best thing. And it was more obvious to the families than it was to the surgeons initially. And I think more surgeons now have evolved toward appreciating these approaches, but initially it was more the families that wanted to have these approaches. And so the families kind of drove the practice, which I think is important, that we do need to listen to our patients and to our families, and what we think as physicians may be the right way to go may not necessarily be what the families and patients want to do. And so I think it's very important to look at that. If you're going to provide the best care, you do have to look at it from the standpoint of the patients and the families, not just what we think is best as surgeons or physicians, but what do patients feel is the best way to go. And many times it's minimal invasive. And when there's equipoise in the outcome between the two options, many people will pick the minimal option, just based on that alone.
Yeah, absolutely. And coming full circle to the first point you made at the very beginning, I think the language we use to describe some of these procedures, like the expanded versus subtotal, that often gets communicated in one way or another to patients, really impacts their perception of what's happening. And so it's, I think, even more important to really explain to patients what's going to happen and what's known about the outcomes.
If you think as a family member, you can really tell the difference, but you understand the difference between subtotal versus expanded. Oh, I don't want an expanded, I want a subtotal. So, yeah, there's a lot of
unless it's a tumor resection.
Yeah, having had family members try to navigate the system for various things can definitely corroborate that. So the importance of educating our patients.
Go ahead.
What's that? Go ahead.
Oh, I was just saying, I've got a question more aimed at fun than serious. I assume you've refereed a fair number of papers in your career. What's like the worst paper you've ever had, like you've read, not like from like oh, there's bad writing or oh, my personal bias, like you've generally like read the study design or their methods and you're like, I can't believe anybody thought this is publishable?
It happens sometimes. People often throw things against the wall. They wonder what's going to stick. So they think, okay, let's just send it in. You might get lucky. Maybe you'll get a reviewer who isn't going to look at things pretty carefully. But I think it's much better to take your time before you turn in an abstract for a meeting or write a paper. Really be critical about it, because the reviewers are going to be critical typically. And it's best to get it right at the beginning rather than have to go back once. And that's, again, I don't want to come back to this bias again, but the first time you review a paper, if you didn't really think it was done well or submitted properly, and then it gets resubmitted, kind of a little bit of you're like, oh, this one again. Yeah, I remember. And so it's hard not to be a little biased, even if they've met all your, if the authors have met all of your responses, but you kind of remember, God, it was so horrible when I first saw this one. And maybe in your subconscious, you're not going to like that paper. So I think it's important to try and do the best you can. Just like, let's just get it in there and see what happens. And then they'll like do the, the thinking is like, oh, the reviewers will do my work for me. They'll tell me what I have to do, and then I'll come back and fix it. And so they'll let me know what I need to do, and then I'll do it, and then I'll get it approved. But I'll get it accepted. But
can't say I've never thought that way.
Do it right the first time.
Yeah, I can't exactly say it's good advice, but I can't say it's never crossed my mind.
Spend the extra time up front. Don't trip at the finish line. Submit it the best you can possibly, best abstract you can put together, the best paper you can do. I'm sick. Let's just get it in there, and then they'll do it for me. Don't do it. Then unless you want your paper published in a journal that you pay money to have it published, right? Which is kind of like it's a big thing in our field, in the fields now, is, how do you handle literature that's published because you paid to have the paper published? How do you compare that to literature that's not of that kind? And that's big. A lot of people fret about this. The rise of the online journal, that is geared towards financial remuneration for publication. That's another topic altogether. So,
maybe we need to take journal publication in the nonprofit sector. You need nonprofit journal publishers.
all right, guys, I'm gonna sign out, but I really appreciate the work that you put in, and I'm very impressed. It was a very, very, very nice discussion and really good papers. I'm very impressed. Thank you for inviting me.
Yeah, thank
Thanks
you
so
so much
much.
for your time, and happy Valentine's Day to everybody that tuned in today. Thank you so much,
Have a
Dr.
great
Meltzer.
evening.
Have a good night.
All right. Any final words of anything there, Nikki?
I really just, want to thank Dr. Meltzer and also Jose in particular. We definitely had some last minute cancellations here, and so we really appreciate the students coming through for us to give those presentations, because as you can see, the faculty appreciate it and have a lot of good input on both publications and just in general about the field. So keep showing up.
Can't really say I'm a craniofacial enthusiast, but I had fun.
Yeah,
maybe I'll have to do this more. Maybe I'll have to pinch hit more often. It'll force me to get out there and learn new things.
Yeah, you gotta expand from the Rad and Nordy show.
Yeah, well, I like how silly we keep it on the Rad and Nordy show. On that note, join us Wednesday, 7 p.m. for Rad and Nordy show. We're talking about funguses that take over your brain on Wednesday, or I guess tomorrow. Oh gosh, I gotta read up.
That is tomorrow.
Oh my goodness, it's right around the corner. I guess. All right. Well, I know what kind of research I need to be doing between now and tomorrow night. All right, go ahead. I'm gonna go ahead and sign off and let you go ahead and shut the stream down after you've made any of your final announcements. Thanks, everyone. Thanks for having me.
Thank you.
Have a good night.
Thank you, Jose. Final announcements. Make sure to register for our Women in Neurosurgery webinar, which is going to be Saturday, February 25th at 10 a.m. Eastern, and you can register on our website. Thanks for joining us. Hey, good evening, everyone. Welcome to the fourth in our Craniosynostosis webinar series, which is our grand round session, as you can see here. Just a few announcements before we go ahead and get started. We want to make sure that everyone's aware that our Women in Neurosurgery Weekend webinar is happening this weekend, Saturday, February 25th, starting at 10 a.m. Eastern. We have a great series of panels lined up for that, so we highly recommend you register and attend. Additionally, we are going live tomorrow, talking about mind games at 7 p.m. Eastern. And then again on the 23rd, also at 7 p.m. Eastern, doing our neurosurgery program spotlight. On New Mexico University School of Medicine, specifically their residency program. The neurosurgery journey also goes live every Thursday at 7 p.m. Eastern, so definitely check that out. And we have our fundraiser ongoing for a brain injury to serve military veterans and patients that have suffered from brain and spine injuries. And lastly, all of our videos can be found on our video library, both through our website and on YouTube, to check out any of these after the fact. So if there's any in the series that you missed that you want to go back and review, we highly recommend you do that. And lastly, without further ado, I would like to introduce Dr. Mark Proctor, who is giving our grand round session tonight. Mark Proctor is the neurosurgeon-in-chief at Boston Children's Hospital, as well as the Frank D. Ingraham Professor of Neurosurgery at Harvard Medical School. Dr. Proctor obtained his undergraduate degree at Dartmouth and his medical degree at Virchow College of Physicians and Surgeons at Columbia. He went on to train in neurosurgery residency at Georgetown, followed by fellowship at Boston Children's Hospital, where he has been on staff since 1997. He is the director of the Brain Injury Center at Boston Children's Hospital, and nationally has been incredibly involved in advocacy and injury prevention. He is the immediate past chairman of the Pediatrics section of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons, and is past president of the New England Neurosurgical Society. Dr. Proctor has particular interest in minimally invasive treatment of craniosynostosis, and he is one of the world's leaders in performing this operation and has studied the long-term effectiveness of minimally invasive craniosynostosis treatment. So without further ado, I'm going to stop sharing my screen so that Dr. Proctor can share his.
Great. Let me just get that going here. All right. I assume you're able to see the screen now?
I can, but you just go into the full screen presenter mode. Perfect. That looks great. Thank you.
Great. Great. So just speak up if there's any issues because I can't see you now, but thanks for the invitation to speak. And unfortunately, I missed the other talks in the session. So hopefully this won't be too repetitive. As mentioned, my real contribution is on the minimally invasive endoscopic treatment of synostosis. So I'm going to sort of weigh that against open treatments, but I'll start with a little bit of a review of what cranial synostosis is. So nothing to disclose here. So I'll start with some very basic embryology and things you may or may not recall from your embryology classes in medical school. But as you look at the skull, it's unlike the other bones in the body. It's a very specific way of bone growing. It's called membranous bone formation. So most bones in the body form by endochondral bone formation, and that includes the bones at the base of the skull below this little line here called the mendosal suture. But all of the major cranial plates are this membranous bone formation. So you start early in gestation on the left here with these little patches of bone that then keep growing and come together. And the little interfaces are called the sutures. So you have the lambdoid suture in the back, coronal suture on the sides, and then other sutures you'll only see from other views, which is the sagittal suture over the top and the metopic suture in the front. Okay, so it's pertinent to go over a little bit of the anatomy to understand how head shapes can be affected. So what are cranial sutures themselves? They're very cellular, and they're what we call osteoblastic. So I always think of the B in blastic for building. So it means osteoblastic means you're making new bone. So these sutures make new bone very quickly. They're very cellular, and they're highly influenced by biomechanical forces. So as the brain is growing and pushing the bones apart, the sutures are growing new bone, like almost at exactly the same rate as the brain is growing. Eventually, that should start to slow down, right? The growth of the brain is vastly complete even by the time you're born, so that you're supposed to slow down. But if it doesn't slow down and you get excessive growth of bone, then that's when you get this synostosis, or the premature fusion of the bones. So what exactly is synostosis? As I said, it's congenital, meaning you're born with it. It's characterized by closure of either one of those sutures, and there's sort of 6 major ones, or more than one of them. And each time a suture closes, it results in sort of a stereotypic abnormality of the head shape. So when we think about synostosis, most cases are what we call sporadic, meaning no one else in the family had it. But there's also what we call syndromes, like things like Apert syndrome and Cruzon syndrome, and I operated on one of each of those today. And those are much rarer. So overall, you see cranial synostosis about 1 in every 2,000 live births, but the syndromes are about 1 in every 30,000. And just so you're familiar with the term, secondary synostosis it's a very different phenomenon. That's what happens if the brain isn't growing. So think things like Zika virus or a neonatal stroke. The brain's not growing, not pushing the bones apart, so the bones fuse together simply because nothing's pushing them apart. So when we think about synostosis, I don't want to say there are no animal models, but there are relatively few animal models. So why is it such a uniquely human disease? And there's 2 predominant reasons. One is we have a large brain, right? So we have a lot more growth to account for in our brains than other animals. And the other is that we walk on 2 legs. So why does that matter? Well, if you think about the weight of a baby cow or an elephant or anything that walks on four legs, all of that weight is on the abdominal wall. So as the mother is walking around, the weight of the fetus is on the abdominal wall, and the abdominal wall is pretty strong. But in humans, because we're walking on two legs, as we walk around, the weight of the fetus is on the pelvic outlet. And as such, we simply cannot hold a pregnancy until we have full brain maturity. So if you think about a little calf being born, it can actually get up and walk away from its mom within a very short period of time, minutes to a couple of hours, whereas humans can't do that, right? It's about a year before they can get up and walk away from their mom. So there's a whole lot of social implications in that, right? It's why we form family units and tend to have separated off into couples, because you have to care for the young in ways that other mammals don't have to. But it's also why synostosis is a problem, because most other animals are born with a full-size brain, and humans don't really achieve that full-size brain till about 1 to 2 years of life. And even then, it's not a full-size brain, but it's substantially complete by 2 years of life, about 90 to 95% complete. All right, so if you think about normal growth of a skull, think of it like a balloon inflating. Each day the brain's growing a little bit, and it's pushing each of the bones apart a little bit. So if you have the sagittal suture here, and the brain growth is pushing those bones out medial-lateral, so out to the sides, if that sagittal suture closes, well, you can't grow as much out to the side, so you grow more in length. And that's called Virchow's law. And basically it says skull growth is restricted in a plane perpendicular to a suture, premature future, and enhanced in a plane parallel to it. Okay, so we'll hopefully get through most of the background here soon, but if you want to just think then, how does the skull grow? Well, here's the normal skull on the left. And then for each of the various sutures that can close, you can see the deformity that results. So we're just talking about sagittal synostosis, which is a long, narrow skull. Well, what happens if this left coronal suture closes? You get flat in the left frontal area. Your ear pushes, well, it doesn't really push back. It stays forward because it doesn't get pushed back. So you're flat and the ear stays forward. Classic sort of deformity. Don't need an X-ray to prove it. Don't need a CT to prove it. Just physical exam should be enough. Lambdoid synostosis, you get flat in the back. And again, the ear stays back because it didn't get pushed forward. And metopic synostosis is one of the more varied ones, and we'll go over that. Okay, so what do you have to distinguish synostosis from when you see a little baby with a head shape abnormality? It's this. It's deformational plagiocephaly. It's a baby who's been lying in a certain way, and because their heads are a little heavy and soft, they can get it flattened out. This really took off in 1992 with the Back to Sleep program. Probably most people listening to this were subject to the Back to Sleep program. So if at this point, if you're under about 30 years of age, you were probably sleeping on your back as an infant, because it reduced the rate of sudden infant death syndrome. But it also has led to this sort of epidemic of flatheads. Really a cosmetic issue more than anything else, but something we probably see 30 patients a week for in our department. Okay, so now that we've gone through what it is and how to diagnose this, let's go through a little bit more of the basics. So how do we assess the shape? I'd say in general, I almost never get x-rays or a CT scan, at least not to make the diagnosis. Why is that? Because once you understand the deformity, you should be able to make the diagnosis just by examining the child. So I think of imaging as an adjunct to surgical treatment, not a diagnostic tool. So here are just some x-rays. If you look at the one in the middle and on the right, this is classic sagittal synostosis, so a long, narrow skull. And here you can see that premature fusion up over the top. But I could have made this diagnosis just as easily on the patient. I didn't really need the x-ray to do that. The view on the left here, this is what we'll call right unilateral coronal synostosis. So this right suture is fused here. And this is a very interesting phenomenon called the Harlequin eye sign. So this little peak off the eye, someone thought looked like a French clown called a harlequin eye. So like I said, any of these diagnoses that you're making on x-ray, you should be able to make on the patient. Do we ever get anything more than an x-ray? Well, sure. So sometimes it's really important to get films, right? So this is a deformity called a cloverleaf skull, and not no surprise as to why it's called that. It's just shaped like a clover leaf. You could see all the skull bones being eroded here. So this is fusion of every cranial suture. And when that happens, the brain starts struggling for room, and it starts eroding the bone. So that's a cloverleaf skull. And it's important to have a CT because you want to understand exactly where the fusions are, and you want to understand the nature of the brain. Scans can also be very helpful for following children over time, right? So this is a child with Apert syndrome. They have bilateral coronal synostosis. So if you look on the left here, the coronal sutures are closed. This is after I'd done an endoscopic release. So I opened the suture, used the helmet, and the head is now lengthened out. And the height of the head, which had been growing too high, started to correct as well. Okay, so now we'll really focus on the surgical treatment of synostosis, and again, get into the nuances of when do you do a big operation and when do you do a small operation. So there's been a real cycle in the treatment of cranial synostosis surgery. If you sort of look to the top right here, in the 1950s, that's when we really first systematically started to treat synostosis. There was some treatment around the turn of the 19th century into the 20th century. Basically, all the kids that got operated on at that point in time died. So for about another 50 or 60 years, there was no surgery for synostosis. But then in the 50s, as surgical techniques started to improve, the operation became more popular. And most of the early operations were big incisions, ear-to-ear incisions, or front-to-back incisions. You do that, you'd move the bones out in various ways. So there's all sorts of different things. I'll show you some of them. And what was found is that, gee, it's a big operation and the results weren't great, right? So in doing these big operations, you didn't always get great results. So people started thinking, well, maybe we should be doing smaller operations. And even though smaller operations didn't always work in the past, maybe there were some new things that would help. So the current era of what we call minimally invasive surgery is doing small incisions, taking out the fused bones, and then using adjuvant therapies like a helmet or springs to correct the shape. So we've really sort of come full circle from these what we call strip operations in the 1950s, got away from them because too often the bones fuse back together, and now we're back to strip operations, but we're doing them in a different way. Okay, so if you're a student that's at a modern craniofacial center and you have a newborn that has synostosis, basically what you're probably going to see is that baby's going to be referred to a multidisciplinary team, and then based on the age and what type of deformity is, et cetera, they're either going to go down the route of an open cranial vault procedure or a minimally invasive procedure. So there's an interesting phenomenon that goes on in this field, is that endoscopic surgeries now has been around for about 27, 28 years. It's actually been shown to be quite effective. There's been more articles on endoscopic surgery than on open surgery. And yet we're a little bit slow to adopt it. So, I'd be considered one of the leaders in minimally invasive surgery, but there's a lot of centers that don't do it, don't do it at all, don't do it very extensively. And the question is why? And I like to use this parallel of looking at laparoscopic cholecystectomy. So for many of you, as you go through your general surgery rotations, you may only see a laparoscopic cholecystectomy. But in the past, they never had laparoscopic cholecystectomy. It wasn't until the 1987 was the first report, but it was really around the late 1980s that it became popular. And it was first met with very significant skepticism. And I think some of these some of these early articles are they're just a little humorous, right? So laparoscopic cholecystectomy, passing fancy or legitimate treatment option. These were all articles from right around 1990. Laparoscopic cholecystectomy, let us control the virus. And, you know, it's a pretty damning way to refer to the operation. Laparoscopic cholecystectomy, fantastic, question mark. So clearly the general surgery population was not adapting this type of surgery very quickly. But then really just within a year or two of that, then we have laparoscopic cholecystectomy, evolution, not revolution. People trying to finally accept that these are advanced techniques, not some barbaric way of doing the operation. And then laparoscopic cholecystectomy, threat or opportunity. So, you know, within, again, just a couple of years, it was made clear laparoscopic cholecystectomy was there to stay. And general surgeons really had to understand how to use that operation. And one of the real things that came out, and this is from that last article, is only surgeons involved with open cholecystectomy and management of its potential complications should perform the procedure. And I think it's very analogous to synostosis. If you don't know how to do an open operation, if you don't fully understand the skull, you can't do these minimally invasive operations. But if you understand it well, then you should be able to do either one. So, you know, this is an article I published now over 10 years ago, endoscopic cranial suture release for the treatment of synostosis. Is it the future? And I think the future is now. I mean, I think if you're treating this condition and you're not able to do endoscopic operations, you're really not doing a great service for the patient. And this is also a task force that I was the lead neurosurgeon on back about 11 years ago, sponsored by the CDC. And basically what we came out saying is that these multidisciplinary teams are really important. Endoscopic treatment is a great option, and you just have to understand how to do them all. Okay, so now we'll just really focus on surgery for the rest of it. So I would say that if we look at the two types of surgery, you've got your open surgeries. These are purely mechanical operations where you're taking off the bones and you're reconstructing them, and it's, you know, sort of like erector set type things. You're really rebuilding the skull. And the endoscopic surgeries they're philosophically very different. You're not taking apart the skull. You're just restoring the anatomy to the way it was meant to be. You're taking out the few sutures and hoping that things are going to grow normally over time. But you're doing that by using some sort of device like a helmet or springs to correct it. And where I put here, conceptually, you're turning synostosis into a deformational problem. For all those little babies that have flatness in the back of their heads from the way they're sleeping, we started using helmets to correct them, right? So this is essentially the same thing. You're turning synostosis into a deformational problem because you're taking out the fusion, you're making the skull bone soft again, and now you're using the helmet to reshape it. So if we look at a condition now like sagittal synostosis, here you have that long, narrow head. In this case, the baby is positioned with the head down towards the bottom of the screen. There's the endotracheal tube, marking out incisions, marking out the various sutures. What are we dealing with? We're dealing with a long, narrow head, right? So here's the actual baby with synostosis next to his CT scans. And here you can see the pretty classic findings. Sagittal suture is closed. The head is bossed out in the front, meaning the forehead's a little overgrown. They're bullet shaped in the back, very narrow, and they have that dense ridge. And the other thing, as you get better at this, you'll realize that the head, normally the highest part of the head should be the very top. And with synostosis, you have this downsloping. So the highest part of the head is the front, whereas it should have been over here. It should have been the vertex of the head. All right, so if we have a child like this, what are we trying to achieve? We're trying to lift the back of the head with our correction. We're trying to widen the back of the head. And as we look at them from the front, we're trying to sort of bring down the peak of the head and make the parietal area here the widest part of the head. Okay, and I would argue that if you look at the bottom right here, what's labeled F, you're trying to get from this shape to this shape, right? You're trying to get it wider and smoothed out on the back. And there's lots of ways you can get there. You can do this. In this case, the yellow represents the incision. So you can make these two small incisions and remove the bone and then use a helmet. You can make the two small incisions, put in springs. So now you don't need a helmet because you're physically pushing the bones apart. Or you can start to do all sorts of variations of big operations. So here you're opening the scalp completely and you're making various cuts. Sometimes we use what's called distractors. These are little pins you go in, and each day the family takes a screwdriver and turns the pin because the pin comes out through the scalp. Or we could do just big reconstruction operations, right? And I think it's fair to say, well, if our goal is to get from one shape to another, isn't it best for the baby to do it in a way that's most physiologic, the least bleeding, the shortest hospital stay, et cetera, et cetera. So now I'll take you through just a simple case of sagittal synostosis. This is the specialized head holder we use for sagittal synostosis. Here we have the baby positioned, injecting local anesthesia, making our incisions, use something called a Colorado needle to open it in an essentially bloodless fashion. Then we're going to get down to the bone here. And we're, doing everything front and back because this is sagittal synostosis. So we have to release that whole long suture. We use a high-speed drill to make our first burr hole. And then we're going to start to open up the bone. And obviously this is sped up, but the whole operation is only about 20 to 30 minutes. So once we get that going, we're going to bring in the endoscope. And you'll see that starting right about here. So that's the endoscope going in. And next I'll show you the view from the endoscope. So here's the bone work we started to do. And now we're going to use the endoscope to push down the dura. You can see that dense spike of bone from the fusion there. That little V shape over here. So we're just separating the dura off of the undersurface of the bone. And there's the burr hole up front. So we've already connected front to back. I think we'll take one more little look under the bone here. And once that's all done, it's just, the brain is safe because you push it away. And we just use a heavy scissor to cut out the strip of bone. And once those cuts are made, you'll see us taking out the bone. I think in this video it comes out in two pieces. So there's one from the back, and here it is coming from the front. But we've essentially just cut out that fused portion of the bone. Put in some gel foam to allow for hemostasis. And then close up the incisions. Pretty straightforward operation. And again, it takes about 20 to 30 minutes. The rate of blood transfusion should be well under 5%. And again, here you can see a child before and after surgery. These are laser scans. These are the scans that are used to make the helmets. So they're actually very accurate. So they're 3D CAD/CAM systems that scan the entire head, then a mold is made of the head and the helmet is made to fit the mold. But you can see the nice correction over time. So let's compare that to some of our bigger operations, right? So what we call cavalry vault remodeling operations. And this is just one method of doing it. It's called the Melbourne method. The plastic surgeon I work with, John Mura, came from Australia. So he likes using the Melbourne method, but you can see it's fairly complicated, right? So first you have to expose the entire skull. And then you label all the different parts because you're moving them around every which way. And here you can see it in the flesh, so to speak, right? So this is that Melbourne method. So we expose the entire skull. We draw out this template. We label everything because once you take it off, you got to know where to put it back. Then I make all the cuts using a high-speed drill. All the bone is removed, right? So you take it off, then the plastic surgeon's working with it on a side table, and starts putting them all back in this very sort of meticulous, structured way. And here you can see as we're getting near the end of everything going back. And here it is at the end, right? So we started with a long, narrow head, and now it's been widened out substantially in the back. It's been shortened a little bit, and it gives a good correction, but it takes a lot longer. Baby needs a blood transfusion. We'll spend a day or two in the ICU, and probably about 4 to 5 days in the hospital. But here you can see the correction. It's a pretty good shape correction, right? So that's the same baby before and after, and you can see skull's been widened out and shortened and also lifted. You see how I mentioned how they downslope, and now they look pretty good. So they're both really good operations. It's just one is a much bigger procedure. And we'll go over how we make the determination of which one to use. Coronal synostosis. So we went over that a little bit in the x-ray. So this is when one of the sutures in the front closes here. And what happens when that occurs? Well, you get closure of the suture. So here's a right coronal synostosis. The eyes always become asymmetric. So the eye on the affected side is much higher, but it's also flatter. So it almost looks like the eye is popping out of the head a little bit, what we call exorbitism. And the nose always tilts over to that affected side. So it's a pretty classic diagnosis based on appearance. So again, how do you correct it? Well, you could do what's labeled B here, where you make a small incision and you just take out that fused part of the bone and then use a helmet. Or you can do a bigger operation where you make that ear-to-ear incision and you take off all the bones and move them into the right place. And again, I'd say if they're both going to work equally well, you might want to think about the one that's least invasive and least traumatic to the child. And this is these are just further examples of helmet therapy. So you see before surgery on the left, during therapy in the middle, and after therapy on the right. You can see it's a very nice correction of the forehead shape. Metopic synostosis, this one is really varied. So whereas we think of sutures closing at about 2 years of age on average, and technically it's actually not until the end of puberty. So the sutures don't technically fuse until all of your bones stop growing, which is at the end of puberty. So suture fusion really should be 16 or 18 years of age, but we stop using them by about 2 years of age. But the metopic suture can be closed at birth, or it can be closed by 3 months of age. In fact, 40% of babies have it closed by 3 months of age. So calling closure of the metopic synostosis is not always correct, because synostosis, the implication is it's abnormal. And if you just have the suture closed, that could be quite normal. So this is a case of clear metopic synostosis, and I'm saying that because the interfrontal angle is below the norm of about 118 degrees. In fact, the norm is 135 degrees. The threshold for calling it synostosis is 118. But this is just what we call a metopic ridge. It's a normal forehead shape. There's a little bit of ridge because that bone closed early, but it's going to go away over the next 3 to 5 years. So you don't want to operate on metopic ridges, but you do want to operate on what we call trigonocephaly, this triangular shaped forehead. And again, you could do that through a minimally invasive operation, through that small incision, or you could do it through a bigger operation where you take off all the bones and reshape them. Just to go a little bit through metopic, here you can see classic trigonocephaly, that pointiness up in the forehead. Here I've marked the fontanelle, marked the course of the suture, and marked where the incision should be at the hairline. This is now the same patient all draped out. Here you can see us infiltrating with lidocaine, making the incision, using the high-speed drill here to get through the bone, have a nice little burr hole here that we then enlarge, and then we use the endoscope to look down, and then use the same scissor to cut out the bone. And here's a look through the endoscope, right? So this is now the edge of the bone. So we've taken out the part in the middle. And this is the left frontal bone and the right frontal bone with the metophic suture now removed. And this is just closing it up at the end, giving a little irrigation, and that's what the incision looks like. It's behind the hairline, so it's really not a visible incision over time. And this is the correction we get, right? So this is, again, just the laser scans. That's right before surgery, and this is after surgery. So you can see you can get a nice forehead correction. And then lambdoid synostosis. True lambdoid synostosis is a very rare phenomenon. I operate on about 100 children a year for synostosis, and in any given year, I'll see maybe 1 or 2 lambdoid synostosis cases. So most kids who have flattening in the back of the head, as I said, it's sleep-related, not synostosis. All right, and we recently published our experience treating that endoscopically, and it works quite well. So can you use it if multiple sutures are closed? And the answer is yes. We would operate if up to 2 sutures are closed, we'd still do it endoscopically. As you start to get to 3 or 4 sutures, probably you're getting to that cloverleaf situation where the brain is eroding so much into the bone that the endoscope might not be safe. And here's a child with Apert syndrome. As I said, they get this sort of high, short head. We take out the bone, treat it. It all lengthens out over time. So this was an article that John Muir and I did, invited review for the 75th anniversary of the Journal of Neurosurgery, and just looking, where's the field heading? And I think where the field is heading is where we see it now, that, these are sorts of conditions we can approach in lots of different ways. So why don't we use endoscopic surgery? I mean, this has been on the website of a very well-known craniofacial surgeon now for nearly 20 years, talking about why we shouldn't use endoscopic surgery. And basically every one of the reasons is debunked. So I'll go through some of them here. That he says, well, correction is not achieved at surgery. So infants must wear a headband up to a year afterwards. And that's true, right? It's if you're going to treat him with a helmet afterwards, then you're going to treat him with a helmet. Most families would prefer that than to the big incisions and the blood transfusions, et cetera. And I put them mostly true because no one helmets for a year. You'll helmet perhaps up to your first birthday, so maybe 5 or 6 months, maybe 7 months. And like I said, should that be choice of the surgeon or the choice of the family? This is another statement made that the headbands are restrictive. They're similar to synostosis because they restrict head growth. I'd say that's unequivocally wrong. Helmets have been really well studied. There have been literally now hundreds of thousands of kids in helmets. And basically what they're doing is they're leaving gaps where you need new growth. They're not a vice. They're not pushing the head into new shapes. They're just allowing for growth into the flat areas. How about why helmets over like springs or distractors? Some of the reasons I like helmets over springs is because, one, you can change the shape in many different dimensions. Springs only work in one plane, so they're sort of two-dimensional. And the other is you can modify it over time. If it's not going exactly the way you want, you can change the helmet, change the shape. Finally, you don't need another operation. If you put in springs, you've got to take them out. So again, the helmets are really safe. They don't restrict growth. This has been well proven and well documented. And these are just various helmets that we see for different conditions. So the top child has bilateral coronal, the bottom right is sagittal, and the bottom left is metopic. How about, are these procedures not as effective? So this is a study I published 3 years ago, and we looked at 500 consecutive patients that I operated on. And I'd say these operations are very, very effective. I wouldn't do them if they weren't. They're not as much fun to do as big operations. They don't pay as well as big operations. We do it because it's the right thing for the child. So if I look at my first 500 patients, you can see this is an interesting phenomenon. About 2/3 of patients with synostosis are boys. And this is because sagittal synostosis, which is half of all synostosis, is 4-to-1 male to female. We don't really understand why, but it's 4-to-1. And age at surgery, you should see, is about 3 months, and that'll come up in a little bit. Estimated blood loss, overall pretty small. Transfusion rates are, you'll see on the coming up slide, is about 5 to 6%. This is just a breakdown of the patients we operated on. You can see 50% are sagittal, as I said, and 7% of them had syndromes. So that's we will operate in the setting of syndromes. Transfusion rate, you see there, 6%. Complication rate was about 1.4%. And then reoperation rates. How many of these kids went on to need more surgery? It was about 3.6%. And we'll compare that in just a moment to open operations. So what are the reoperation rates after open surgery? It's actually higher, right? So this is a really well-known group down in Washington, D.C. Their reoperation rates after open surgery was 5%. This is reoperation rates for syndromic synostosis, and going anywhere from about 25% up to 100%, depending on which syndrome you had. So when you have a child with synostosis, you have to be prepared for them to fuse sutures back together and need more surgery, regardless of the type of initial operation they had. This is the group from CHOP, basically showing a real degradation in outcomes over time. So when you do these big operations, you're taking the bones off, you're putting them in the position you want them to be in, which is great, but they don't then grow normally over time. And I think this is different from endoscopic surgery, and I'll go over that in a bit. But this is one of the top groups in the country, basically saying Whitaker class 3 or 4, those are poor outcomes, was about 38% of their group. How about reoperating because intracranial pressure developed? That's pretty common as well in synostosis. This is one group from Pittsburgh where they had about 1.5% of their kids developed elevated ICP. This is a group from Portland, 6.2% of their patients developed elevated intracranial pressure. This is just something else that surgeon said, well, you shouldn't do endoscopic surgery because of the risk of holes in the head. No, it just doesn't happen. I've done 500 operations. Only 2 kids have had a hole in the head that I had to correct. I'm sorry that I've now done 800, but the article was 500. But skull defects they're well known after craniofacial surgery. Whenever you operate past 8 or 9 months of age, the skull doesn't regenerate the way it does in an infant. So it's skull defects are a known problem. How about, are these operations more dangerous? Some people still contend that the endoscopic operation is more dangerous because you have a restricted field of view. This is my first 100 cases, mean operating time 48 minutes, mean blood loss 23 mLs, 8 transfusions, and that's in the first 100. Mean hospital stay 1 day. The long and short of it is these operations are much safer. It's like not even comparable. Transfusion rates from as high as 90 to 100% in open operations, and as low as really these days, my transfusion rates are about 2%. So a verdict, I'd say by all morphologic measurements, they're comparable. Like, you shouldn't choose open or endoscopic based on the outcome you want. They're both going to give you great outcomes, but endoscopic surgery is much safer. And it's very well published. Like I said, it's now more published than open operations. How do you follow children after the surgery? Closely. So, if you're going to commit to doing these sorts of operations, you have to see the kids back about every 1 to 2 months in the first year, and then once a year for the next 5 years. Why do I say for the next 5 years? So why do we follow the kids till they're about 6? Well, you have to understand the way the brain grows for that, right? So if you look at the brain weight over time, essentially it's reached 100% between 5 and 6 years of age. right? So we obviously all get smarter over time, but it's not because our brains are growing more. It's because they're sort of rewiring and maturing in other ways. But if you follow a child with synostosis till they're about 5 or 6, you'll have caught all the kids who are going to develop the elevated pressures. And this is just another more advanced study showing the same thing, greater than 95% complete by 6 years of age. So when you're following a child with synostosis, you got to follow them until they're at least 6. Most kids that are going to need more surgery will probably need it by 2 or 3 years of age. But if you don't follow them until they're 6, you're going to miss some kids. This is just an example of a child who was treated endoscopically, right? Here's bilateral coronal, opened up the coronal sutures. They look okay, but what happens over time? They close their sagittal suture, they close the metopic suture, and they started to close both coronal sutures. So kids with synostosis are just more likely to fuse their bones. I mentioned a little bit before what's called the neosuture. So why might endoscopic surgery actually be better than open surgery? So when you take off all the bones in a big open operation and you put them back with plates and things, you never develop the normal sutures again. So whatever bones you take off, you lose those sutures. But when you do these minimally invasive operations, this is the same child before and after surgery. You can see the eyes leveled out, the nose got straight. But even cooler is that they formed a completely normal new suture after I removed the fused one. So this was an article I published on that, but this has now been seen by multiple centers. So here you take out a fused sagittal suture and you get a normal sagittal suture. You take out a fused lambdoid suture, you get a normal lambdoid suture. Here's another case of apron. Take out 2 fused coronal sutures, you get 2 normal coronal sutures. Why is that so important? Because those are going to grow normally over time. And that's, to me, probably the primary advantage of this operation over the bigger one, is you get normal growth through the lifetime, which you often don't get after the bigger operations. How about the cost value? We're almost at the end here, so just hang on a few more slides. What do you think is a cheaper way to treat this? Not even close. So we looked at this and then multiple other centers have looked at it, and they all came to the same result, that treating a child endoscopically costs about 40% of what it costs to treat them in a big operation. And this is everything. This is including the helmets, including the gas mileage to get to your helmet appointments. You could look at everything, and it's still a far cheaper way to go. And as we're really looking, probably many of you are studying this a lot more than I did when I was a medical student, about the value of healthcare. So you want an outcome that's meaningful to the patient, and you want it at a cheap cost. So if that cost is low, the value is much, much higher. I would argue this is a far more valuable way of treating the condition. So in the appropriate setting, both types of surgery are effective. How do I decide how to do it? Well, if they're 3 to 4 months of age, I'm probably going to go endoscopic. If they're over 6 months, it's really not going to work, because the driver of the growth is the expansion of the brain. And by 6 months, it's already slowing down. Severity, there are some cases that are just too severe for endoscopic. They're rare, maybe a few cases a year that I see where I say, I can't do this because it's just too complex. Whereas the open operation you can do on anyone. Reoperation, endoscopic, because it's a time-limited operation. If you've done it and didn't work, your bailout's going to be the open operation later on. So you can't redo endoscopic operations with another endoscopic operation, and obviously family preference. So in conclusion, there's lots of literature that, like I said, first article came out in 1995. So nearly 30 years that show that the endoscopic surgery is safe, it's effective, and it's reliable. I'd say all of the theoretical concerns about the disadvantages are just not borne out by long-term experience. And the outcomes are really pretty equivalent between the open and endoscopic surgery. Endoscopic, far more value. And I'd say at this point in time, if you're going to go into craniofacial surgery, you really need to know how to do them both. And if you don't, number one, it's a disservice to the patients, and number two is they're going to go somewhere else, so you're just going to lose the patients. All right, just this is partial references that I published on the topic, and hope that was helpful, and happy to take any questions.
Thank you so much, Dr. Proctor. That was excellent. Feel free to throw your questions in the chat. But while we wait, I was just kind of curious about sort of the training for any kind of endoscopic procedure, in particular this one, what the learning curve was like for you, and that sort of, it seems like, as you mentioned, there's been a lot of resistance to transitioning from open to endoscopic, and what your experience has been with that as you have gone through the training.
Yeah, so when I was a trainee, I couldn't really train in endoscopic surgery, so it's a little bit self-taught. David Jimenez, who's a neurosurgeon down in Texas, he and Constance Baroni, who is a plastic surgeon, they developed the technique. So many of us sort of learned about it from them. I'd say most people going into neurosurgery now, this will be standard training. So anything, any field you go into in neurosurgery these days, you're going to learn how to use an endoscope, which is different from when I was training. So it might be for tumor removal. It might be for treatment of hydrocephalus. It might be for some spine operations, or it may be for synostosis. But the learning curve should not be nearly as steep, because it'll just be a basic part of your training.
Absolutely. We do have a question. Why and how is unilateral hearing loss caused in hydrocephalus? That might have been.
I'm not sure I know the answer to that question. It's certainly a non-synostosis question.
Maybe they meant, I'm not exactly sure.
So you can see hearing loss in certain synostosis conditions. There's things like Muncke syndrome or Seth-Rich-Oatzen that are inherent features of which are hearing loss. In hydrocephalus, I really don't know if that is the true question. I'm not sure why you'd have unilateral hearing loss. Next question.
Next question here. I'm trying to put that on the screen. How long does an open procedure for craniosynostosis, normally take compared to the about 30 minutes for the endoscopic?
Right. So I mentioned that today I did 2 operations. One was minimally invasive and one was open. So the minimally invasive one I did in one room, starting at 7:30, while the anesthesiologists were putting the other patient to sleep and putting in the line. So I was done with the first patient. The endoscopic surgery indeed took like 30 minutes. They were out of the room by about 9:15 in the morning. The operation, actually the skin incision on the second operation, was made at about 9:30. It was made by the plastics surgeon. So that both patients went in the room at 7:30 this morning. One was out at 9:15 and the other was out at 3 in the afternoon. So just to give you a sense. So the open operations are roughly 4 hours, and that's by a pretty experienced team. And that's skin to skin time, right? Not the entire surgical time.
Thank you. And then one other question. Do we have an idea of what is the cause for early suture fusion?
Yeah, great question. We have lots of ideas, right? So we now can find the gene for about 1 in every 5 cases of synostosis. So for, let's say, Apert and Cruzon, which I've been talking about a fair bit, we know the genes for both of them. It's both FGFR receptors. One is FGFR2, the other is FGFR3. We know lots of other genes, the twist gene and other genes that cause synostosis. Still to this day, there's lots of cases of synostosis where our genetic capability is not strong enough to fully discern. But we know that even a child that we call sporadic synostosis, so that their sutures fused, but no one else in the family has it, their child has a 1 in 20 chance of having synostosis. So these are not just, they're not random occurrences. We just can't always find the gene. So I would say, in my view, all cases of synostosis have a genetic cause, and we're just not yet smart enough to know what it is.
Yeah. And I imagine it's, as you mentioned, with animal models being difficult to establish for this condition, it's also difficult to further study how you might manipulate gene expression to help treat the condition.
Yeah, exactly. There are, I mean, you can manipulate the genes, and there's certain fish models even, which is funny to think of fish having synostosis, but it's, there are very few, outside of a couple of breeds of dogs, very few models of naturally occurring synostosis.
I had one last question about, I recently came across a study that was kind of looking at overall for craniosynostosis, not specifically looking at endoscopic versus open, but they looked at long-term outcomes and found some differences in working memory in a long ways down the road from these initial procedures. Are you aware of any studies that are starting to compare this long-term sort of intellectual or neuropsych outcomes?
Yeah, so that's really a great question. We are similar to genetics. We understand a lot less about this than we want to, and then we will in the future. Definitely, if you look at big cohorts of kids with synostosis and without synostosis, and if you think the IQ normalizes to 100, right? That's that any population should normalize their IQ to 100. Kids with synostosis, it tends to be 1 to 2 points lower. So if you look at big cohorts, the average IQ is about 98 to 99. So there's definitely a little bit of a shift. The vast majority of kids with synostosis are fine, and probably would be fine even if you didn't do surgery. But some of them are not fine, and we're just, we're really just starting to learn more about what impacts that. Is it doing an earlier operation helps because, well, you're releasing the brain earlier? Is it doing an early operation doesn't help because you're exposing the brain to anesthesia earlier? Is doing a shorter operation better because they're exposing a baby to less anesthesia? So these are all things we're still trying to work out the best paradigm. The only really big study ever done looking at intellectual outcome in synostosis found a breakpoint of 1 year. So it's like kids who were operated on before a year seem to do better than after a year, but the study is like 40 years old now, and it's really not relevant to modern surgical techniques. So it's pretty clear though that if you let a child develop elevated pressures and then don't operate until then, that's going to be somehow detrimental.
Absolutely. Okay, looks like we have maybe time for one last question here. Can the endoscopic be done to a 7-month-old baby? So if you're out of that, 6-month window, are there any situations where you might consider doing endoscopic anyway?
Yeah, so it's a really good question. So if you think of the growth curve I showed you, you're past the peak of the growth curve, so you're not going to get as much push of the brain. If you decided you'd use something like springs, well, the springs are going to do some of that pushing for you, so you can push the envelope a little bit more. I would say the oldest kids I've ever operated on are really right in that 6 to 7 month range. But I will say that I was recently at a meeting with David Jimenez, and he's going to be publishing soon a series where they've been doing this surgery up to 9 months of age, and he said that the results were pretty good. I haven't seen it, but he's one of the most experienced endoscopic synostosis surgeons there is, and he says he's pushing the envelope out. So I'd say theoretically you can, although there's no doubt in our series, the kids that were closer to 3 months had better results than the kids that were done older.
Interesting. We'll have to keep an eye out for that study. All right. If there are no more questions in the chat, then I think we can go ahead and close things out. Oh, wait, one more question. Are there any other sequelae that have been identified with craniosynostosis procedures?
It's a pretty broad question, so I'm not sure exactly how to answer it. I could, obviously, I said a lot in only 45 minutes. I could talk for days on synostosis. It's really the majority of what I do. I mean, there are lots of other sequelae, and there's some of these syndromes have lots of other systemic abnormalities, fusions of elbows, hands, feet. So I'd sort of need a little bit more specificity on the question, but there's a lot. Synostosis in neurosurgery, we've tended to think, well, if you could take out a brain tumor, you know how to work with the skull, and synostosis is nothing. But the reality is it's a far more complex subject than people have given it credit for.
Okay, well, I think with that, we can let people get back to their evenings. Thank you so much, Dr. Proctor, for your time and your expertise. That was an excellent talk. Really hit on a lot of really salient points, and got to cover more of the endoscopic side of things, which really nicely rounded out our series here. So thank you again so much for your time. And thank you to everybody that tuned in. This recording will be available on our video library, as I mentioned earlier. And please tune in on Saturday for our Women in Neurosurgery Weekend webinar.
Great. Well, kudos to you for doing this.
Thank you. Have a good night.